Yeah, nice.
Okay. Good morning, good afternoon, good evening, wherever you are in the world. Welcome to the third webinar in the series of Asian EUS group webinars on interventional EUS. This has been a very encouraging series of webinars for us, and we are seeing increasing number of responses and increasing countries joining us over the past three webinars. So today we have people or delegates or whatever you call them from 65 countries joining us. And mind you, this is a highly selective webinar. This is only for EUS, and that too EUS specific stents. So we are very encouraged by this response. Thank you very much, all of you who are joining us today. I will not be able to mention all the countries from where you all have joined us, but I'll mention a few. Chile, Bangladesh, Brazil, of course, Hong Kong and India have major contributions. Then Korea, Japan, Israel, Iraq, Morocco, Mexico, Saudi Arabia, Philippines, Thailand has a very big contingent. Korea has lots of people joining in. USA, 25 people had joined in, and UK, France, very nice list. Italy. So thank you all for joining and spending your time with us for the next 4 hours. I should thank Olympus, Cook, Teoh, and of course Boston Scientific for helping us with these efforts. And it is really makes us very happy at the response that we get from these. So today's webinar topic is very close to my heart, and the idea I got of the webinar from a discussion which I had with Dr. Nageshwar Reddy a few months back. So we have endoscopists, we have great endoscopists, and then we have innovators. Innovators are no doubt great endoscopists, but they also think continuously of how to improve upon the procedures, how to bring in technology so that our life as endoscopists become easier. So we were having this, I was having this discussion with Nagi on what makes a person an innovator. And this is the basic theme. It was there at the back of my mind, and we, after discussing with Lawrence and Anthony, we decided that this should be our, hi Eli, Professor Eli Agoto is here. So we decided to have this webinar. I thought this would be a bit serious theme, but I'm very happy that about 650 people are joining us for this webinar. And I think that is because of the faculty that we have been able to have with us. We have people who are really great endoscopists and great innovators. So a good combination of both the things. And I hope the next 4 hours that you spend with us will give you pearls of wisdom from not only so you will yourself, all of you will think of innovation as something very integral to endoscopy. May I request Lawrence to take over from here and tell us something about the AEG, and then of course introduce Nagi.
Okay, thank you very much, Vinay, for this opportunity. Can I maybe use a slide and share the slide? Yeah, I thought, well, since our audience is getting more international, and some of you may still not be familiar with what this group is doing, I think Vinay asked me to perhaps a few minutes to introduce this particular group, which hails from Asia, obviously, Asian EUS group. And I think we have been doing all these workshops as well as webinars recently, as well as for quite a number of years. So essentially, this group was formed in 2012 and currently has expanded its membership to encompass almost all countries in Asia. There's only one endpoint for this particular group, which is to try to improve EUS adoption through training. And how we do the training is we have been very lucky that there are many trainers around in Asia who are very willing to share their knowledge, expertise with other people. So I think in doing so, we have been very successful in trying to match the needs with the so-called, I think, our supply of trainers. So obviously, I think most of the training has happened before the COVID time. So I just very quickly take you through those memories which we have cherished. Essentially, we've done a lot of local workshops in many different countries and train the trainers, horses, as well as more recently interventional workshops. And obviously, I think we also have been quite effective in imparting this sort of skills as shown in a few publications. And more recently, I think Vinay has pioneered this Mumbai school in a bid to say that, well, perhaps I think workshops are short-term. If we can also come up with something more long-term, such as a school, then it will be even better for the trainees. So I think that has been done. And then obviously, I think before this particular COVID time, we were able to meet together and then come up with so-called consensus guidelines. And this is perhaps the sort of crown jewel. In every 2 years, we were organizing the Asian EUS congresses, perhaps the biggest EUS-specific congresses in Asia so far. And obviously, I think this year, as everybody knows, is a very extraordinary time. And this is marked by the social distancing. And because of that reason, I think Vinay and Anthony have taken upon themselves to organize a different form of workshops to continue on the so-called EUS training. They have started this monthly AEG webinars with hosting alternating between Mumbai and Hong Kong. It's still a learning curve for us, but I think so far they've done extremely well, I must say, in terms of technology. If you notice some of the webinars, there was live case demo. It's not so easy to actually get 3 images in one particular Zoom so-called. You have to have fluoro, EUS, endoscopy, and a room view. It's not easy, so there's a lot of learning involved. I think more importantly, now actually we discover that we can now reach out to many more people. I think the first workshop, which was organized by Vinay, there were 924 registrants. And the second one in Hong Kong, we actually exceeded 1,000 registrants with 600 over attending on the same day. So I think this is again the third one. And judging from the Mumbai webinar, more than 90% found the webinar extremely useful. So this is where I'd like to actually congratulate Vinay for again doing it again this time. I'm sure it will be very successful. So congratulate Vinay, and then we will go on straight to the session proper. So thanks again for this opportunity. So maybe I think at this stage I would like to say upon take the theme forward. I think you mentioned about innovator, and certainly I think without much introduction, we all know that Nagi is not only a good, excellent, world-class endoscopist, he's also very, I would say, extraordinary innovator. And most importantly, he is also a so-called world leader. He has established a world-class Asian Institute of Gastroenterology. So today, we are very honored to have Nagi to talk to us about his innovation, which is called Nagi stent. Please.
Thank you, Lawrence. Thank you for that kind introduction. I'd like to thank the AEG, especially Vinay and Lawrence, for giving me this opportunity. When Vinay asked me to talk on the Nagi stent, I was a little embarrassed because you're talking, I have to keep mentioning this name all the time, and it looks a little odd. Yeah. So let me start first by my conflicts of interest. Actually, it's a confession. And the confession is that I'm not an endocrinologist. The topic we're dealing with is predominantly in the domain of endocrinologists. I'm actually an ERCPist who has a passion for using the side wing scopy. And my journey actually in treating these patients started with the side wing scope. So what I'm going to do over the next few minutes is to give a brief background of how this idea came, how it actually developed, what's the current status of the Nagi stent, and what are the future that I see. Now, in 1990s up to 2010, what we're doing is that we were draining this pancreatic, peripancreatic fluid by the technique using side wing endoscopy mostly. You see a bulge there, we'd make a small opening and then put in a stent. Sometimes there's a thick fluid like this, which was, many of them were actually wands, which were sometimes infected. We used to do a balloon dilatation. Now, all of this without endoscopic ultrasound guidance. It used to be purely using a side wing endoscope. The concept of using endoscopic ultrasound came a little later when Shyam Vardharajulu showed clearly that this was superior to using an endoscopy. So our concept was to actually dilate this tract. We are lucky very often because there were no complications, but when we achieved enough dilatation, we'd go in directly to do a necrosectomy sometimes. But this was a procedure which was not very safe because of potential problems of these large dilatations. And one such experience we had during a workshop, you can see actually Todd Barron here, who was the innovator for starting this type of transgastric procedures. So this was one of our workshops at Hyderabad. He was doing this, and you can see that we dilated this opening to about 15 millimeters to enter inside, and as soon as we dilated, you can see the massive amount of bleed that's coming out. In fact, this patient almost bled to death. What quickly we did was to put in a large esophageal stent, through the scope esophageal stent, to actually stop the bleed and to open this up. So this gave us an idea that probably because of several problems that these stents have, that we should think of something else that should be done. Because whenever you do intervention with plastic stents in these cases, we have to do repeated interventions. There was increased chance of sepsis and of course potential complications like the one you saw now. So the other option was to use these covered stents which are already available to us at that point of time. The biliary stents, which are 10 millimeters. They had larger lumen. They had an expansion after they dilated. It was quite adequate many times to drain the fluid better than plastic stents. But the problem with the standard biliary stents were the very high migration rates. The edges were very sharp, and there was, because they're very long, the incidence of blockage used to be quite high. So although for a short period of time, this was in 2008, the paper from Mikhail Kahela, for a short period of time we were using these biliary stents, we stopped using them because of these problems. So we're looking at a stent which could be, remember, not endoscopy ultrasound, but under the guidance of side wing scope, which could be used, which was easy to insert, which decreased the need for necrosectomy, which had a low complication rate. And that's when I got this idea. This was in 2009, when I got this idea based upon another stent at that time, which had just come in. This was the EUS stent, which was being used in Amsterdam to create an anastomosis between two lumens of the bowel. In fact, this was very early work that was being done by Jenin and a group, where they were using this in actually the animal model. This was an animal model to see if they can create anastomosis. So I also looked at what the cardiologists were using. The cardiologists for ASD and BSD were using occluders. And this was the basis I thought we should make our stent for draining these peripancreatic fluid collections. And you can see this was ideally the stent which we thought of. So I gave this idea to to Teoh at that time, which was a meeting in Korea when I actually talked to. This was Yongil Hong, who was a brilliant engineer with Teoh. And I gave him this idea, and within a week he came out with drawings and all that. This was in 2008. He came out with his drawing saying that, is this, with this concept, do you think this stent is okay? Of course, it went through several phases. The first stent which we made, the edges were only 16 millimeters. So we knew that we had to enlarge this. It was, of course, completely covered. we had to have a lasso, because we pull on a lasso and only then it actually shrunk and came out easily. The edges were initially very sharp, so we had to smoothen this out. The initial angle was 35. We knew that this was not sufficient. Migration rate was still high. So we had to increase it to 53 degrees and have flares which are sufficiently big to avoid migration. Now remember, the concept at that time was not to create a lumen opposing stent. My idea was to use a side wing scope, to use a very broad stent with high flares, which can drain this peripancreatic fluid easily and which could be removed easily. So you can see finally what happened was the sharp edges were all taken out. The third prototype was finally made, was available to us about 2011, which was what the current Nagi stent is with this lasso. This was the history of what actually happened. These ideas were given 2008 and 9. We made the first prototype. A lot of animal work was done at this period of time. And after the animal work was done, we started using this stent in our own unit before actually it was commercially available. So for a year, we're using this stent, very, very encouraged with its use. Again, mainly we're using at that point of time, using a side wing endoscope. Because by that time, the concept of endoscopic ultrasound for some reason hadn't yet come in. And then we started, and of course, further progress has been made with the hot Nagi now. Of course, Teoh was quite happy. They started to sell a lot of these stents. The basic concept was to keep a short stem. The stem, actually, we made 3 stems, 1 centimeter, 2 and 3 centimeters. We found that the most comfortable one was 2 centimeters to insert it through the side wing scope. Through the EUS, of course, you can have a shorter stem, but through the side wing scope, you must have at least 2 centimeters. Because if it is 1 centimeter, it was misplaced very often. The Japanese preferred a 3 centimeters one, so when Teoh made it for the Japanese, they made it 3 centimeter stem, longer stem. Of course, the inner diameter was 16 centimeters. We now have also 20. And the external flaps went up to 22.5, and it was a completely covered stent. So this was the concept. It had different lengths, and the delivery system was 10.5. So this was the original stent. Now, when the stent came, they didn't tell me this, but they called it the DNR stent. Now, DNR could mean in US, do not resuscitate. So which was a dangerous thing for a stent to have. And again, I said, no, I don't think this is acceptable. You just call it pancreatic fluid stent or so on. But they came up with this idea, which was not very good for me, because one, it's a little odd to be sitting in the audience and somebody keeps talking about this. And also, a lot of people think that I get a royalty from this stent, which I don't. In fact, I buy these stents also for myself, unfortunately. And what has happened over a period of time, they have sold a lot of stents, but I don't make anything out of it, which is also unfortunate. I think Ken would tell you the same thing also. Ken Binmoeller is talking to him. So at this point of time, Ken and, not Ken actually, it was a company, Lumina, and me had a little misunderstanding. I was actually doing all this development without knowing what is happening in Lumina. Lumina, Ken had this brilliant stent, which was doing the lumen opposing, and Ken was an endosonologist, so it was more ideal. He was creating this stent, and Lumina thought that we had copied the idea. We didn't even know that they're having the stents, and our stents are actually predominantly for side wing scope. Of course, later on, Ken and we had a laugh when we discussed this later on, and we made up for this. So this is the first stent being applied in 2010. We did the first procedure in our unit, and you can see we're using through a side wing endoscope, done typically with a small balloon dilatation, and then putting in the stent. And what was exciting for us was that unlike plastic stents where you could really dilate a lot, we didn't have to dilate much, and we could actually go inside the stent immediately and do a necrosectomy. We don't do this now, the concept is different, but at that point of time it's exciting. So the first workshop where we demonstrated this stent, I think Vinay would remember this, was in 2011 when we had our annual meeting of the SGI at Vizag. And you can see again, we're using a side wing scope here and then putting the stent inside. So this was a side wing scope along with fluoroscopy was the way we used to use this stent. In 2012, Itoi and me, Itoi came over to our unit to put some of the stents, and together we published this first paper in Abdominary Pancreatic Sciences, and we demonstrated that this stent was very useful in situations of want. And you can see that we could go through the stent and do a necrosectomy also. And this is just to show that Itoi is involved with both the stents, the Nagi stent and the Axios stent. He was the first author for both. He did this with Binmoeller in the first case report. In fact, the first case report was by Binmoeller and Shaw in 2011, but this was the paper that attracted the most attention, and similarly ours was at that point of time. So of course there are many stents now. I think Dr. Moon is here. He was responsible for the Spaxus stent. One of the good things is that most companies now decided not to have a name to these stents and not to have a person's name, which I think is good, because then you don't get associated with these stents. There are other stents, like for example the Axios stent, which is now available in Germany, the Hanero stent. So at least 5 of these stents are now available based on the initial concept. They have different types of expansile stents, strengths and so on. So ideally, I think the actual placement, Vinay is going to talk a little later on. So in India, our experience has been predominantly with the Nagi stent, because this was the only one available till recently, till the Boston came up with the Axios stent, which is now available here. But it also cost factor was not so high, so therefore a lot of Indians started using this. And then of course came the concept of using with endoscopic ultrasound. So because the stent was initially designed for side wing scopy, it took some practice for endocrinologists to use this stent to get used to it, because you can see in endocrinology, when you're using it through the EUS scope, the luminal part is blind. So sometimes there's a potential chance of misplacing the stent inside. So we have to be very careful in pulling it out, and the last part, watching it through the scope so that you put it in accurately. And over a period of time, of course, it becomes very easy to do this procedure. And you can see that it was fairly dramatic. There's a large wound here, and after 4 weeks, the whole thing is drained off completely. One of the first reports outside India came from Japan, which was Yamamoto's group, who actually used this in a series of patients. So in Japan, after India, the most commonly used place was in Japan, followed by other Asian countries, including Australia. And it was actually Mukai and et al. Again in Japan, who pointed out the difference between the so-called lumen opposing stents, which is the Axios stent, versus the biflanged metal stent, which was the Nagi stent. The concept was totally different. The migration rate you see with the lumen opposing stent is much less compared to Nagi stent, but our concept is migration should occur. So what we mean by migration is when the cavity collapses, the stent shouldn't push against the opposite wall. It should fall off into the stomach. Or when you're doing an actual necrosectomy, it can actually fall off, but you can replace it at the same time. So this was the flexibility of what we created this stent, that we wanted a stent which wouldn't oppose the wall, so that it shouldn't rub against the opposite wall, because that can have consequences, and it should drop into the stomach spontaneously. So therefore, although at that time migration was thought to be an adverse event, it was actually more often not that. Mukai pointed out that the advantage of the Nagi stent was the stem, which was a little longer, 20 to 30, versus a shorter stem with the Axios stent, and that's because it's the Axios stent, you have to place it very accurately. Of course, once you become an expert, it becomes easy. The delivery system was much easier for us endoscopists doing ERCP, because it's exactly like putting in a biliary stent. And of course, finally, the incidence of bleed was much less with Nagi stent, because the concept was to have very smooth flares, and most of the time the stent drops off after a certain period of time. The first multicentric trial with Nagi stent was reported by Amol and his group, along with some Japanese colleagues, when they actually looked at 21 patients with pancreatic fluid collections with a very high technical and clinical success rates, with no adverse reaction in these patients. Again, complication is stent migration was very little in these patients, and hemorrhage, of course, is not very common with Nagi stent. The first series which actually compared this stent along with the plastic stents again came from Japan, from Mukai's group. The majority of the metal stents in this group was actually the Nagi stent with few Axios stents, but they compared it with plastic stents. And what they found was the only main difference was that the time for intervention was much less with this stent compared to plastic stents. And this was one of the advantages then. Subsequently, in 2018, the Italian group actually published a large multicentric study. More than 67 Nagi stents were used in this group. Majority of them transduodenal. Again, transgastric is much easier than to use transduodenal. And what they did is, you can see they used a 19-gauge needle or a cystosome. We have been using the cystosome quite a lot because we find that makes it much easier. Sometimes the wall is soft, you can use directly, or very often you require a 4 millimeter balloon. Again, this is something that I think Vinay is going to talk on, so I won't go. But the technical success is very high with these stents. And this is very important. This is what we're emphasizing. With this stent, we do not advocate direct endoscopy necrosectomy. Only a very small percentage, only about 10% will actually ultimately require direct necrosectomy with the Nagi stent. Of the adverse reactions, again, you can see that bleeding is very less. In fact, in their series was 0. This is the difference between Nagi stent and other stents, both Spaxus and also the Axios stent. I think the reason is that this stent, the flaps are very soft, and because it's a 2 centimeter stem, it tends to move up and down, so that when the wall comes in it against, it moves towards the stomach. And very often the migration of the stent is into the, you can see 7.5 migration. Usually it's 10% in most series. The migration is into the stomach. There have been, at that point of time, many stents, but you can see predominantly most of them were using Axios. Few were using Nagi. Mainly this was from Japan and from Australia. A large series from Australia was also reported with the Nagi stent, but predominantly in the Western world. In Europe, Nagi was available after it got registered, but it was not available in United States, so still not available. The other thing they did with Teoh did, I don't know whether right or wrong, is they didn't patent the stent. So it's non-patented, and anybody could actually copy this stent. How does this stent compare with other stents which are for pancreatic fluid collections now in the market? There's one bench study and one clinical study. The bench study was by Anthony Teoh and his group from Hong Kong, who clearly showed that if you look at the strength of the stent, the tissue opposing stent of the strength of the stents, the best would be the Axios stent, followed by Spaxus. Now, the Nagi stent has got an extremely low lumen opposing activity, and this again is what the stent was designed for. This is not a lumen opposing stent. It's a biflange stent, which is very specific to pancreatic fluids, and because it doesn't have the lumen opposing capacity, it's not an ideal stent for gastrojejunostomy or a gastrogastric anastomosis and so on. So the clinical study comparing this Nagi stent along with the Axios stent was done in a study which again came from Europe, and you can see clearly that there's not so much of a difference between these two, except that a little higher migration rate occurs with the Nagi stent. Again, not very significant. So this particular study where they compared this Nagi with lumen opposing stent showed that there was not much difference between both the stents. Again, our concept was this is a stent that should be used to drain the fluid, and we should actually avoid the necrosectomy as much as possible. So based on this, we actually did a study where we looked up whether we can do an endoscopic step-up approach instead of going for direct necrosectomy using the Nagi stent. And this is a study that was published in GIE sometime back, where we took 375 patients who underwent endoscopic drainage. Majority were using this special Nagi stent. Plastic stent was used in some cases where there was a gross disruption of the pancreatic duct, where the stents had to be kept for a long period of time. So what we did was, after initial assessment, some of them improved. Those with persistent symptoms, especially majority of them had an infected wall, were drained. And what we found was that of the 153 cases that were drained, 49 required re-intervention. And the re-intervention was very early if there's a clogging of the stent, and we could do declogging with the endoscope, or sometimes if there was still persistent non-clinical success, then we put a nasocystic tube. And if still it continued to be a problem, usually about the second week, then we do a direct endoscopic necrosectomy, which was only 11% of our patients. And this was the concept of the Nagi stent, that it's one of the problems with this stent is getting blocked here, and we have actually now we have overcome this, and what we're doing is routinely we put a double pigtail 7 French stent through the Nagi stent, and we find that this complication of clogging is much less, and so also the migration. If there's still fever not responding, we put an NCT with irrigation, sometimes with hydrogen peroxide, and in a small percentage of cases, about 10%, we actually do a direct necrosectomy. So this is the final figure showing that majority of the cases can be treated without necrosectomy. A very small percentage require this. Of course, there can be complications, and we learned using this Nagi stent over a period of time that the complications can be overcome. For example, bleeding can be overcome. The incidence of bleeding is very less with Nagi stent, but even that small incidence can be overcome by early removal. And this is thanks to based on some very good work by Vinay, probably show that if we remove the stent by about 3 weeks or 4 weeks, then chance of bleeding is very less. Migration can be avoided by putting a double pigtail stents. Perforation, of course, can be avoided by choosing the right type of case. And because the stem is a little longer, the chance of perforation is very less. And if the stent gets into the mucosa, we often use an APC to take out the stent. If the stent is mal-deployed, and this is one advantage of Nagi stent, the stent is mal-deployed. Unlike other stents, you can actually pick it up, reload it, and use it again. Or actually, once it goes inside, you can use the lasso, pick it back, and put it back in the right shape, like we use for completely covered stents. And this is one of the advantages we had. Now, we have also seen that using this stent, the recurrent rates depends upon the type of the disconnected pancreatic duct, and this is from paper from Vinay, which probably will be showing later on. And he also showed that early removal of these stents resulted in less bleed, and we could actually predict which patients would recur. For example, if I had a patient whose chance of recurrence was this, then we put a plastic stent in this case, not a Nagi stent. And this is some very useful information that we got. This stent has also been used in other situations. For example, although we don't advocate it very strongly, this is a study which came from Hong Kong, and you can see that they've used this stent in a patient with peripancreatic fluid collection after surgery. So this is again something that we used very often. Post-surgical peripancreatic fluid collections are a basis we use. There's been reports of using this stent from Australia in malignant ascites, although we won't advocate that. Stent also has been used in afferent loop syndrome. This is a paper from Sudipta Dhar from CMC Vellore, where they've used it in afferent loop syndrome. There have been subsequently many papers, although classically it's Axios stent which have been used in afferent loop syndrome. Even the Nagi stent can be used very successfully, and this was a patient of ours who had a very large afferent loop syndrome, and you can see that the stent has been very effective. This is something we won't advocate with Nagi stent, but reports have come of using this with gallbladder drainage. As I said, this is not a lumen opposing stent. If you have a patient who's got a very chronic cholecystitis, the gallbladder is stuck to the duodenum, you can get away by using this, but generally we won't advocate this stent for gallbladder drainage. Although you can use it for pelvic abscess. This is a report which came from France, from Mark Giovannini group, and they used this stent in a patient with pelvic abscesses, and they showed quite that it was quite effective. So what is going to be the future now? Based on this, the Axios stent and the Nagi stent, there are many hybrid stents that are being developed, and I think we also have Moon here there with us. We're going to talk later on the type of stent, Spaxus stent, but this is a hybrid stent which came from Hanaro company, where they combined the Axios stent with Nagi stent. So you can see that what they're having is a flap which turns back, which is partly tissue opposing, but very important, they have this longer stem. So this stent is a combination of both. It's a very stiff stent, a combination of Nagi and Axios stent, and they believe, in a report that they just published recently, that this stent may be quite the future of combining both the stents. I think many more innovations are going to come in this area. In fact, at that in 2015, we proposed this combined stent where you have a needle, a balloon to mildly dilate the tract and then go inside directly, especially if the tract is very tough and you can, just using cautery may not be sufficient. This is still not developed because the hot Axios came, and then of course we now have the hot Nagi stent, which is made by Teoh. It's registered now for commercial sale. It's available in I think Korea, but we've been using this now, and we've reported a series where we use it just like Axios stent. So one of the important things from these innovations is that each of the innovation is taking help from the other innovation to make it better, to make it much easier. And then you can see the Nagi stent is just like Axios. The stent is similar, but the delivery system makes it a little more easier to use. So I think the indication, as I can look at, these specific stents are increasing, not only walled-off necrosis, but I think with stents like Axios, which I think is a brilliant stent actually. You can do gastrojejunostomies, you can treat benign strictures, you can also do gallbladder drainage and also create fistulas, but you can also drain a lot of abscess. So the horizon of indications has markedly increased using these stents. And you can see this that our imagination is the only limitation here. I think these stents, which are a completely different type of stents when compared to a standard biliary or pancreatic metal stents, are game changers in the sense that for cavities which are very close, which have to be drained, these are the stents that we're going to look for. And I'm sure in future, there are going to be many, many more innovations in these types of stents. Some of these stents are going to be used for drug delivery. Some of these stents are going to be used for obesity, and so on. And already we have actually used the edge of the Nagi stent to make a sleeve, a duodenojejunal sleeve for type 2 diabetes. So I think a lot of other innovations are going to come. I'm sure we can look forward to this in future. Again, I'd like to thank AEG, especially Vinay and Lawrence, for giving me this opportunity. Thank you very much.
Thank you very much, Nagi. Really nice lecture from the authority, inventor of Nagi stent. Perhaps I have a few questions from the audience. If there's any other questions, can you all just type it into the Q&A so that we do not lose the questions? So everyone is welcome to type in their questions into the Q&A. Then I will try to get the answers live from the speakers themselves. Just very quickly before I ask the questions from the audience, just one thing. I think you mentioned that the Nagi stent is actually not supposed to be a lumen opposing stent, isn't it? So what do you think are the use cases? I think the ideal use cases for Nagi stent.
Yeah. So
fluid collection. Any other good use cases for this sort of stent?
So because this is not a lumen opposing stent, typically it should not be used in a situation where the organs are moving. For example, stomach and gallbladder, they tend to move with respiration, and this stent will get dislodged. So ideally is to use it in areas where there's a fixity between the two lumens. For example, like a VON base already formed. So therefore, Nagi stent we would not recommend for early VON. We have to wait for 4 weeks. Although Axios has been used for second week or third week, I wouldn't recommend that for Nagi stent. For pelvic abscess or any other abdominal abscess which have to be drained, it could still be used very well because most of them are chronic and they are fixed structures. So therefore, it's very used. Also, this is something that should not be used for gastrojejunectomy. I've seen people actually trying to use this for gastrojejunectomy. This is going to be a disaster because of peristalsis, the walls are going to move and this does not fix it. So the advantage of this stent, as I said, is that there is this movement of the stent which can occur so that you don't get into problem in terms of the opposite wall hitting. And this also is a disadvantage because you can't use it in other situations. Again, I think because this is a very long stem, the chance of tissue ischemia is very less with this stent.
Okay. I think you did mention that there's a reduced bleeding with the stent. Is that because I think the stent actually migrated out before you have the chance to get bleeding? Okay. So can I just ask, there's a question from the audience asking, how can we manage perforation of one wall during necrostectomy? I think this is not specific to your stent, but again, I think it's something which is useful, especially which is important, especially when you are putting a stent in. How do you manage it?
So this, I think there's so many other experts also here, they can also add in probably. But generally when there's the perforation, recognize it immediately. The important thing would be that with all these stents, you can finish the procedure. And what we would often do is to put in an additional double pigtail stent in the main stent so that the stent doesn't get dislodged. Whereas this is a little different from what happens with, say, Axios stent. If you put an Axios stent and perforation occurs, then this may mean that very often you have to go for surgery because this is fixed to the gastric wall, you can't manipulate. Whereas with Nagi stent, you can actually get it in a little deeper into the other side and then put in a double pigtail stent. But of course, the surgeon should be on hand, should know what's happening. If its contents are like an infected fluid, you have to be careful because I think early surgery in this case is very important.
Okay. The next question is, I think relating to this is, what is the
minimum distance?
What should be the minimum distance of the pancreatic wall from the gastric wall in order for you to place the Nagi stent safely?
So the general rule is when you're using the stents is 1 centimeter is what is generally recommended. But in Nagi stent, because we have 2 centimeters and we also have 3 cm Nagi stent, you can actually go up to 2. Maximum is 2 centimeters, not more than that. But usually 1 is what we normally take. 1 centimeter or less is ideal, but you can extend up to 2 because of the stem, which is much larger. Again, this is different from lumen opposing stent, which is, it's very important that to limit it to 1 centimeter or less.
Okay.
Yeah.
This was one last one before I switch over, because some of the questions can be also answered a bit later on when Vinay comes on, because I think there are more technical issues. But this one is regarding the follow-up. I think the question is, how do you follow this patient and to know whether the stent is clotted? I'm talking about blocking, I think. So how do you actually look at it? Do you need to rescope, or when do you rescope? And then if it's indeed blocked, do you actually, what do you do to unblock it or replace it?
So normally what we do is a clinical follow-up in these patients. Generally when the stent gets blocked. So this stents, what we normally do is after putting a stent, we do an endoscope, we do an ultrasound, plain per-abdominal ultrasound after 3 days, after 1 week, and again after 1 month. So the patient is asymptomatic, there's nothing, if the size of the lumen is decreasing, then we don't do anything. We don't actually stent, we don't endoscope this patient. But if the patient develops clinical symptoms, fever, abdominal pain, and so on, then we go in endoscopically. Usually this happens within the first 48 hours if the stent is clogged because of necrotic material. We can then declog this endoscopically only, completely. And now what we're doing is routinely putting a double pigtail 7 French stent, 7 French stent, 7 centimeter 7 French stents, and we find that this prevents markedly the stent clogging. So if the patient is again symptomatic, it could be either because of stent getting blocked, which can clear, or it can be a migration, early migration stent, which could be easily replaced. In fact, now salvage Nagi stent is very common in our unit. We use the same stent, which can be used in this patient. And sometimes if it is more than 1 week, then you can actually push the stent through the opening directly by stretching this stent, or you can reload it and then put it again. So this is sometimes done. If the patient still is symptomatic, the size of the cavity is not coming down, especially the fever is a predominant component, then we use a nasocystic tube in these cases. Usually this is done after 1 week, nasocystic tube to clear the stent. So this is how we clinically follow. Clinically, only follow symptoms of the patient and ultrasound, abdominal ultrasound. Only if they're symptomatic, the size of the cavity is not decreasing symptomatic, then we do an
this question is about just EUS. So I will ask Nagi, Vinay, if you don't mind, and then after that I'll come to you. Okay. So this one is on the use of Nagi stent in esophageal stricture. The question is whether this is.
So this is the question asked.
Indication.
Yeah, off-label, but we won't advocate use of Nagi stent in esophageal stricture, although the Axios stent has been used in esophageal strictures, in pyloric strictures, because that is lumen opposing, it's okay. It can be, although, actually it's not so easy to use even Axios with an upper GI scope. It's very easy to use it with an EUS scope, but not so easy with upper GI scope because your control is not so good. But Nagi stent should not be used for esophageal strictures.
Okay, so there are lots of questions. Sorry, I think we ran out of time. I'll try to get some of the questions answered by Vinay. Otherwise, I think thank you very much again, Nagi.
Thank you.
I'll go on to the next one. I have the pleasure of introducing our next speaker, who is actually the organizer of this webinar, Vinay Dhir. He's going to be, he's an EUS guy, so I think it's very appropriate for him to share with us all the intricacies, the tips, and also the pitfalls of using Nagi stent in doing the various EUS guided therapy. So I think Vinay, please.
Yeah, hi. So we had from Nagi fantastic lecture, and all the background and the studies have been given by Nagi. So what I will and so it will be a very, very practical talk on how we have been using the Nagi stent at our department. We have been using it for almost a decade now, and we have become a little wiser. So this video is just to show you the date. This is 5th of March 2011. So Nagi, probably it was a prototype which we placed first. So this is our probably the first Nagi that we placed, and it is almost a decade. And if you see the steps, see 19 gauge needle, passage of wire, cystotome, then CRE balloon. So we borrowed lots of ideas from the previous pseudocyst drainage and Vaughan drainage experiences, and we applied them here. And so this is our initial way of doing Nagi stents. And over the past 10 years, the basics have remained the same, although there have been certain modifications as we have become more more knowledgeable about the problems and other things. So before I start on this, what is very important for us is to assess the cyst or the pseudocyst or the Vaughan. Does the patient really need drainage? Who are the patients who need drainage? Those who have a large collection which is causing symptoms, or those who have an infected collection. So these are the two indications. Almost 30 to 35% of patients who come to me for drainage, I say no. I say, please follow up. These patients don't need a drainage. So first and foremost is to ascertain, does the patient need a drainage? Because every procedure has potential of adverse events, and you should not be causing adverse events in patients who really do not need drainage. The second question you should ask is this fluid collection or pseudocyst suitable for EUS guided drainage. So how do you determine that? You have to see on CT scan or MRI that there are well-defined walls. So the walls should not be broken. There should not be fluid tracking into multiple areas. The collection should be close to the stomach or duodenum, as Nagi mentioned, about 1 centimeter. How much is the necrotic material within the collection? So MRI gives you a fair idea of that. Because that you should decide beforehand whether this patient is going to need some necrosectomy or you can get away without a necrosectomy. And then what is the size? So whether the patient needs an endotracheal intubation before the. So we do not do endotracheal intubation in all our patients, but if a patient has a large collection and we expect the contents to come up into the mouth, then of course we do endotracheal intubation. So these are some of the basics we need to know before we start the procedure. It is extremely important that when you put in your EUS scope, you assess again, spend some time on looking at the collection. What is the distance from the stomach and duodenal wall? Are there really collaterals in the puncture trajectory? Very, very important, because very often these patients have thrombosis either of the splenic vein or some other veins, and then you will find many vessels around the fluid collection. So please, I will show you, please see that there are no collaterals in the trajectory of the puncture. If there are, choose a different site for the puncture. Then also assess what is the amount of necrotic debris that is there and whether there will be any further need for necrosectomy. You should be ready with all the accessories that you have: a 19 gauge needle, 0.035. We use a stiff guide wire, a 6 French cystotome. We use a 6 mm biliary balloon nowadays. We used to use CRE before, but 6 mm dilator, then of course Nagi stent, and also keep some plastic stents with you. So be ready with the accessories and then start. So this, according to me, is the most important part of your entire Nagi stent placement, and that is a careful cyst evaluation. So this is a patient I did today morning, and so I quickly made a video and I'm showing you. So you see here, very nice collection, but you should withdraw your scope slowly over the entire edge of the fluid collection and see if there are any vessels. See, I'm now withdrawing my scope slowly, looking at the entire collection, looking at whether there is a debris or not. In one view, you may not find, but if you change your angle a bit, see here, you will start seeing that there is debris here. This looks like a scary vessel, but it is not. So all these things are important. And then of course, apply Doppler in the entire cyst area and especially in the gastric wall and in your puncture trajectory. So your puncture is going to come from here. So you have to be very careful in this axis as if there are any vessels or not. So carefully evaluate the entire cyst. You will see towards the junction, you see vessels have started appearing. You see there, these are the vessels. See this? Now, if I puncture from here, I'm increasing the chance of bleeding. So avoid this area. Don't puncture from here. So these are important things. Spend some time before you really. So as I'm coming proximal, you are seeing more and more vessels here. So this is a dangerous area. And also you see the distance of the cyst from the stomach wall is going on increasing. So this is not the nice place. We have to go in and carefully see. It's also a good practice to up tip your scope a bit so that the gastric wall is a little relaxed. Then you can see intragastric collaterals. You see here, there are small intragastric collaterals here. So this evaluation, you need to see the distance. So we are measuring the distance now and the collaterals. So you can see obviously this cyst is not compressing on the stomach wall. It's a bit away, but the distance is 7 millimeters. So this is about okay. We can proceed, and we have to now find an area where there are no vessels, no major vessels which are likely to bleed. So you see I'm going distal now. I'm already expecting that when I puncture, there might be some bleeding looking at the vessels that are there, but I am trying to now go toward this area where there are probably less vessels and I can puncture from there. So this assessment is very important. This cyst is large. You see, this is about 9 by 12 centimeter fluid collection. So I have already requested my anesthetist beforehand to put in an endotracheal tube so that there is no aspiration after the procedure is finished. So these are some of the important things, because after the procedure, a gush of fluid comes out, and then you have aspiration that can be really, really dangerous. But not all patients need endotracheal intubation. So this is about the cyst evaluation. You also saw the wall of the fluid collection was very well defined. So we didn't see any tracking of the fluid anywhere. So this looks like a good cyst puncture. Needle puncture is straightforward. Those of you who are doing EUS guided biopsy know that. Only thing is, most of the times you will puncture in a corner. You know, we would like to go here, but it doesn't happen because of the peculiarities of the EUS scope. So this is another patient, not the same patient. You see here, same things are being done. You are assessing the wall, you are assessing the distance from the stomach wall, and then see the puncture usually comes in this angle. It doesn't come in the center. And once you have punctured, you pass your wire and make about 1.5 coils. Use a stiff wire, 0.35 inch. Don't use a soft wire. So see, this is being coiled here. About 1.5 coils is good enough. And that's about it. This is a simple thing, needle puncture and wire passage. Here, what is most important is for you to realize that once you have got a good position to puncture, you have to learn to stabilize your scope. That is the single most important thing, because if I have passed my wire here and I dilate here, and then suppose my scope has moved up a little, about a centimeter, then the stent will come like this and it will not puncture. So keep the position, very important. And how do you know that you are keeping the position? On EUS, at all times, you should see the wire at all times. If you are seeing the wire at all times, you are safe. There is no problem. Your axis is good. You can go on doing the various steps. Tract dilation, again a very straightforward thing. You don't have to do much. If you are seeing the wire here, I'm showing you the biliary balloon. You can see the two lines here. So this is the biliary balloon. This is the case I did today. So I have just took the liberty of taking some video for you. Normally I don't put contrast in my balloon. This is just for, so you dilate it nicely, 6 millimeters. That is usually enough. Sometimes you find difficulty in knowing where the balloon is, so you go by the markers. It's exactly like ERCP. It will tell you where the gastric wall. It's a fairly straightforward procedure. Sometimes I have seen in conferences, not experienced myself, following dilatation, there can be a gush of bleed. That usually happens with the CRE balloon, so we have stopped using a CRE balloon. But if it is there, don't worry, you already have a wire inside. You quickly place a stent, it will mostly stop the bleeding, so not to worry about that. A stent placement, so you see this is the wire here. I'll go through this quickly. So you have pushed your stent in, and then you ask your assistant to deploy the stent. So slowly, so you see here, this is the distal flange. So we are pulling it a bit up. There is a middle mark here, which you should always keep close to the gastric wall. If you don't do that, then there can be problems. So you see here, sorry, this is again made today, very fast video. And then keep the wire in place and place a 7 French, as Nagi was telling you, place a 7 French double pigtail stent through this. So this patient did have hemorrhagic fluid coming out today. So we are observing him because this patient has portal hypertension. So the steps that you have to remember in stent placement is you have to deploy the stent in the scope. The final part of the stent has to be deployed in the scope. That is number one. Concentrate on the middle marker of the Nagi stent. If you keep the middle marker close to the gastric wall, and then most probably you will not make mistake. We have tried doing it full EUS, we have tried doing it with fluoro, but as Nagi told you, the best way to do it is, you may find it a little difficult, but try to see the last part deployed under your endoscope. That is the safest way of doing it. What about hot Nagi? Hot of these patients. Now you just use the Nagi stent. So it has a cautery at the tip. You see, this is the cautery. You have gone in. You can actually do it without wire also, but initially it is safer to do. See here, this is the middle marker. Keep it close to the stomach wall and then gently withdraw. Ask your assistant to withdraw the thing. See here, it is opening. Slow, careful movement. There is no hurry. So now it's a beautiful, beautifully deployed distal flange. Once you have done this, shift to endoscopy. So you shift to endoscopy and see the stent. See, this is the proximal part of the stent slowly being deployed, and this is a beautifully deployed hot Nagi stent. So you see, we have not needed dilatation in this hot Nagi stent. We may not need wire placement also, but right now it is new, so we want to be safe like we did with Axios. So we still like to use a wire before you place a hot Nagi stent. So this reduces the steps. If you need later on to do a necrosectomy, it's fairly easy. So these are the standard things. I'll go through it. So now you here see, Nagi also showed you these things. So here there are multiple things. It's a little tedious process, but you can do it carefully and bring out large chunks of necrotic material. See, this is dirty fluid coming out. You can use hydrogen peroxide to clean it and make it a little loose and then clean it. So needs a long time, needs a lot of patience, but those patients in whom it is required, it has to be done. If you place a plastic stent initially, the incidence of your doing necrosectomy really comes down because the debris blocking the mouth of the stent is avoided. So necrosectomy can be done safely through the Nagi stent. If the stent comes out, there is nothing to worry. You can replace it without a problem. Yeah. So this is, if you do it with a lot of patience, at the end of it, you will, this is too much of necrosis at one go. And so what I do is I push my scope against the mouth of the stent so that it doesn't fall out. But sometimes it does fall out. So not to worry, you can replace it. And that is something I like about the Nagi stent is its flexibility. It reduces the chances of severe problems. And then you can hope to get a cavity like this, which is fairly clean. You can see here, it's a very, very clean cavity now. It's a very large collection. So this is for necrosectomy. Stent migrated during deployment. It does happen. So please don't get worried if it gets migrated during deployment. There are ways to deal with it, and these are not difficult ways. Suppose when you are deploying the stent and the stent completely goes inside, what do? Absolutely not to worry. You can place another Nagi or you can place 2 plastic stents and then call the patient after 3 weeks, go inside the cavity and pull the Nagi stent out. It's absolutely no problems. If the stent has migrated outside into the stomach, then it's even easier. You can place the stent very easily again. The same stent you can place again. But you have to always remember, please retain the guide wire till you are satisfied with the stent position. If you have lost the guide wire, then there is a problem. So retain the guide wire, see that you are happy with the stent position, good fluid is coming out, then only withdraw your guide wire. As long as you have the guide wire, you are safe. So this is, you see here, these are only pictures, I don't have a video. So this is from the duodenum. We placed a Nagi stent and it migrated completely within the cavity. So we just placed a fully after about 3 weeks, we went in and removed this Nagi stent. So this is problematic at that time. You feel, oh, you lost a Nagi stent, but can be recovered. Patient mostly will not have any major issue. I think that is my last slide. Thank you very much.
Thanks a lot, Vinay. Yeah, lots of questions, but I don't think we have the time because I think we are running a bit short. So maybe I think 2 questions relating to the practical tips. And one question is on, do you have any tip or trick for drainage of wound with a lot of solid material? It makes the procedure difficult to do, even with the Nagi inside.
Yes, it is a challenge, and this is a very, very good question. So, as I said, you have to assess all these things before you place a stent. So, assess the amount of debris that is there. I will do endoscopic necrosectomy up to about 50%. So, if you have half fluid and half debris, I am okay with it. But if it is 80% debris and 20% fluid, I would probably avoid and call my surgeon. That is my personal opinion. There is no data to show that. But I would say it becomes too much work. The chances of complication probably increase with multiple necrosectomies. So half or less than half of the volume of the cyst, if it is debris, then in 2 to 3 sessions, you can remove it. And also try to avoid initially. And as Nagi said, and as AIG has shown in majority of cases, maybe you don't need a necrosectomy. So if necrosectomy can be avoided, very good. If it has to be done, assessment in the beginning is very important. It is a full cyst of full of debris, I will probably say no, I will not do it. Nagi, what is your?
Yeah. Absolutely agree with this, Vinay. I think 50% is the cutoff we take. If it is less than 50%, success is very high. But if it is more than 75%, immediately, no, we just send off to our surgeon. Between 50 to 75 is a gray zone, but I think we prefer more fluid. If it's 50% more fluid, then it's much easier. Absolutely same thing.
What do you do?
Which one?
Brother, not hearing me.
Okay, so another question, actually, this was asked by two people. Okay,
Yeah.
so they asked something relating to wall of necrosis. Is what is the percentage of necrosis in a wand before you decide to drain it? Is there a cutoff in terms of percent?
So we just discussed that. I think it's the same that find out what is the solid debris. See, fine debris is okay. If you saw the first case that I showed, today morning's case, that has fine debris. So I'm not too bothered. I'm more bothered about bleeding in that case. But the necrosectomy case that I showed, beforehand only we know that this person will probably need a necrosectomy. We are very happy with 30%, 40%, 50%, but more than 50, I personally try to avoid and not go for necrosectomy.
Okay, good. Just very quickly, which biliary dilator do you normally use? If you choose a biliary dilator.
The hurricane. I use the hurricane. Yeah.
Okay, I think that's it. Okay, so we are going to move on. I think Vinay, you're going to take over the chairing, isn't it?
No, I think Lazaro is here. Lazaro, can you please
Yes, I
announce?
am.
Yeah, can you please introduce Professor Moon?
The next speaker is the Dr. Young Hoon Moon. He's going to talk about the idea, development, and future about the Spaxus stent. Thank you, Dr. Moon. You can begin, please.
Welcome, Moon. Welcome, and thank you very much for agreeing to be part of this webinar. We are really honored. So we want to hear from you your ideas about Spaxus stent.
Vinay? Vinay?
We can hear you, John.
We can hear you. We can hear you.
Okay. Thank you very much, Mr. Chairperson. It's my great honor to join this fantastic meeting, especially thanks to Vinay and Asian US group. Everybody knows the stenting with conventional metal stent is the insertion of a stent through the structural segment in organ by percutaneous or endoscopic approach. Like this figure, very familiar to us to make the kind of stenting. But the stenting with lumen opposing metal stent is the insertion of a stent through the non-structural two organs to connecting two organs by a metal stent by endoscopy. So it can make many problems. So we need a completely different designed stent to make to prevent a kind of issues. So Axios stent was the first lumen opposing metal stent by Boston Scientific, but originally by our friend, by Dr. Ken Binmoeller and ex-Lumina of the United States. So after development of this stent, Ken became the glorious emperor of interventional US world. Its own very specialized, very useful delivery system and deployment. So I think Ken is the genius, developed the kind of system. So all procedure of stenting can be done by operator himself. So Ken made many assistants got laid off after development of Axios. With the lamps, not only by drainage, we could make access route for possible transluminal traveling into the target organ. So it's the evolution of metal stent. Also, the indications of EUS guide drainage can be expanded with lamps. The first clinical result can be was reported by Dr. Itoi and Binmoeller. And after then, we have a lot of results of Axios from large-scale multi-center study from European countries and also United States. However, still we have some challenging points of Axios like this. This is a new lumen-opposing metal stent, a Spaxus. It has a 25 millimeter large anchoring flange, and the length of stent is 20 millimeter. After complete folding back of the kind of large anchoring flanges, the distance of two flanges is just 7 millimeter. So our team and Teoh Medical of Korea developed this stent. It is the first drawing to suggest the company to make the kind of new stent. So it's on just a conventional 10 French conventional delivery system, not on specialized delivery system. This animation shows the deployment of Spaxus on conventional delivery system. So the kind of deployment is much different with Axios. Just very familiar with like a routine conventional metal stent. Already this slide showed by Nagi. Anthony compared the EUS specific metal stent on different types of anastomosis. Axios and Spaxus shows a higher lumen opposing force, but the Axios was the highest lumen opposing forces. And Spaxus has some advantages comparing with other stents, like it has a long length of stent, but this distances between two flanges is very short. It's 7 millimeter. It can make an easy procedure. So another advantage is it can make a accommodable apposition according to wall thickness of anastomosis, like this. This video shows a successful recapturing of Spaxus even after complete deployment of distal flange. Another advantage is it has a kind of stent diameter for the purpose of drainage, like a drainage of oldham necrosis or gallbladder and CDS. Our group reported the first clinical result of EUS guide drainage using Spaxus, and following Korean multi-center study and Asian multi-center studies results shows a high technical and clinical success rate and very acceptable adverse event rate. Let me show some cases. This patient performed the EUS guide drainage using Spaxus in 60 millimeter for the drainage of 1 after puncturing. Stent distal flange is deployed. And then endoscopic view shows the deployment of proximal flange. And you can see the drainage of fluid contents from 1. With insight of stent, now gastroscope is inserting inside the necrotic cavity to make a necrosectomy using many weapons, snare, and forceps. We should use every accessories to make a clean cavity. And finally, you can see the pinkish background. It means regenerating back wall, and almost complete necrosectomy was done through the Spaxus. And this video shows the EUS guided gallbladder drainage. The procedure is same, puncturing and inserting Spaxus into the cavity. Distal flange was deployed on EUS and fluoro. And then proximal flange deployed on endoscopy. You could see the gush of purulent bile from the gallbladder. And gastroscope is inserting inside the gallbladder through the Spaxus immediately. Now you can see the surface of gallbladder, and we can perform white light image and MBI. Also, gallbladder. For this patient suffering acute suppurative cholecystitis, after stent introduction with Spaxus in 10 millimeter, now gastroscope inserting inside the gallbladder, and on direct visualization, stone can be removed with basket like this, make a removal of all gallstones from inside the gallbladder. This case shows EUS-guided choledochore duodenostomy with Spaxus in 8 millimeter in diameter. After puncturing, the distal flange is deployed on EUS, and then proximal flange deployed on endoscopy. After deployment of Spaxus, ultraslim scope is inserting into the deep portion of bile duct for some kind of intervention through the Spaxus. Recent development for lumen opposing metal stent is one-step puncturing and stenting using introducer system capable of electrocautery catheter. With that kind of new development, most critical tract dilatation step can be skipped on EUS-guided drainage. Can develop one-step EUS-guided drainage using hot Axios, having electrocautery enhanced delivery system. With the development, now can become God of our world. Especially the result of EUS-guided gastrojejunostomy markedly improved with hot Axios. Also, Spaxus stent has cautery enabled access catheter for one-step EUS-guided drainage. This animation shows a deployment of hot. And let me show a case. After puncturing of Walden necrosis with 19-gauge needle, and now hot Spaxus is penetrating the gastric wall without any tract dilatation. And now distal flange is deployed, and then proximal stent is deployed in working channel. Now we developed a Spaxus version 2. It has a shorter length and then small anchoring flange to make a high apposition power. Amazingly, it's on 9 flange delivery system, so it can make a more easier penetration. Let me show this case. This patient have a inaccessible ampulla by infiltrating a pancreatic cancer. After puncturing a bile duct, Spaxus 2 introduced in bile duct without tract dilatation. It's a 9 flange delivery system. After deployment of distal flange, and then proximal flange is deployed, and finally CDS is made. We are also developing new bipolar electrocautery enhanced delivery system to reducing tissue damage by electrocauterization, and also no need of return electrode plate. This video shows a EUS-guided gallbladder drainage on animal study using 16 millimeter Spaxus on bipolar electrocautery enhanced delivery system. After penetration into the gallbladder, Now distal flange is deployed. And then proximal flange is deployed. You can see the gush out of the content of gallbladder. Heparigogastrostomy is the creation of new fistula between upper stomach and left intrahepatic duct. So it has several issues for EUS guided heparigogastrostomy. Especially fatal stent migration was reported after EUS HGS. So we developed new Spaxus HGS having 20 millimeter of proximal anchoring flanges to make a folding back. It can make a prevention of migration, and it can serve access port of bile duct. It has a 2 kinds of diameter and 3 kinds of lengths. You can see the nicely deployed proximal anchoring flange. Let me show a case. After puncturing, dilating, and Spaxus HGS is introducing over guide wire, and stent is deployed slowly. You can see the nicely deployed proximal anchoring flange. And then ultra slim scope has 5.2 millimeter of out diameter is introducing through the Spaxus HGS. Now scope is on bifurcation and CHD. This is endoscopic view. Now slim scope is introducing through the stent. Here is the inside of stent. And then you can see the nice bifurcation of bile duct here. And also you can see the previously inserted plastic stent. And here is the common hepatic duct. So we can make some intervention through the stent. In conclusions, lumen opposing metal stent can make effective drainage and also accessible route for intervention through the gut wall. With the continuous development and improvement, we can make a better success and safety and effectiveness to provide better care for our patients. Thank you for your attention.
Thank you, Moon. Thank you very much. Hi, Takao. I see you.
Hi, Takao.
Hi, hello, Doctor. Hello, Dr. Moon. Thank you for your excellent lecture. I have 3 questions. The first question: how to follow the patients after
what kind of purpose of stent? Like word of necros drainage or gallbladder drainage or CDS?
CDS.
Oh, for CDS, so usually absolute indication for CDS using Spaxus is malignant biliary stricture. Like as I shown my presentation, like obstruction of distal CBD by the heavy infiltration pancreatic cancer can be the absolute indication. After stenting, just the usual follow-up is enough, like follow-up X-ray to make sure the location of Spaxus inside. And usually a Spaxus stent is very rare to migration, so almost routine follow-up is enough.
Thank you. What is for you now the most important indication for Spaxus stent placement?
Oh, as I showed my presentation, there are 3 major indications, like especially wall of necrosis. Pseudocysts can be managed by just the plastic stents or conventional metal stent. But the wall of necrosis, we should expect about the necrosectomy. at that point, luminal purging stent like Axios Spaxus is much better. And number two is gallbladder drainage. We need more discussion about indication, like absolute indication or relative indication of gallbladder drainage. And three is CDS, choledochoduodenostomy. Also, I showed my last presentation. I modified the Spaxus for HGS drainage. So it's another indication for that kind of thing. So I would like to emphasize using that kind of lumen opposing metal stent, we could make some intervention through the stent, not only drain. So that's for intervention through the stent.
Okay, thank you. And always do you put pigtail?
Pigtail, good questions. So pigtail usually only for drainage of wall necrosis because of two reasons. One reason is sometimes that kind of large necrotic material can block even large bore Spaxus, large bore stent. And so we can prevent impacting that kind of necrotic material, the large bore stent. And second one is there are reports about the possibility of high incidence of bleeding to contacting distal end of back wall. So using combination of double pigtail stent can make reducing the kind of chance of bleeding. So two reasons.
Thank you very much for the excellent question. I don't know, Vinay, if you want to do any question more.
Yeah, there are one or two more interesting questions from the audience, Moon. One of them is, so you showed a lovely video of the HGS.
Yes.
So there is a question about whether you can pass the scope immediately or do you wait for a few days? And then
very good questions. We need more studies about proper time to entering scope. Now
yeah.
I think now I did cases after 1 week, but
okay.
But the 1 or 2 stent can make migration to proximal. So maybe I think after 1 month is the best time to make entering.
Okay, 1 week.
How about your opinion, Vinay?
I haven't. I have been using tubular stents for HGS. I haven't used a Spaxus so far for HGS. I will. Now that I saw your video, I will definitely use one.
Okay, I will send it to you immediately by Federal Express.
Thank you. Thank you. There is one last before we let you go, Moon. So you have done a or do you let it forever?
So
if you remove, when do you remove?
Our institute absolute indication is the malignant obstruction of the take-up cystic duct. So at that time, permanent placement of Spaxus. But for the benign cases, almost cases is a non-surgical candidate. So we would like to put the Spaxus in life a long time. But sometimes we are trying to remove it, but it's safe, no problem.
Does it cause any problems in a lap chole afterwards? Suppose you have removed a Spaxus stent and patient goes for cholecystectomy. Is there any problem after that or no?
Fortunately, there was no problem after removal.
Excellent, excellent. Thanks. Lovely lecture.
Thank you. Thank you.
Nice talk.
Thank you so much.
Thank you. Our next speaker is Dr. Pradermchai Kongkam from Thailandia. Nice to see you, Dr. Kongkam. Thanks for to be here with us. The lecture is about tips of Spaxus stent.
Pradam is no stranger to anybody who is here. He's a very well-known figure in interventional EUS. Welcome, Pradam. You have been doing Spaxus stents for quite some time now. So we want to learn from how to properly place a Spaxus stent.
Right. Thank you for giving me a chance. Thanks, Laszlo and Vinay, for kindly introduce me. So please.
My name is Dr. Pradermchai Kongkam from Thailand. I am the current president of the TAGT. I would like to thank my friend Vinay Dhir and the AEG very much for inviting me to give a talk today. Today my talk is about practical tips of the Spaxus stent. As you are seeing in this slide, this is lumen opposing metal stent. Once we deploy lumen opposing metal stent successfully, one farther side of the stent will be hooked to the wall of the target organ. The other side will be locked with the lumen to prevent migration of the stent. The stent can be deployed by endoscopic ultrasound echo endoscope. Steps of EUS guided drainage. In general, for EUS guided pseudocyst drainage, gallbladder drainage, biliary drainage, we start with puncturing process, then dilation the tract, and then stent placement. To puncture into the target organ, generally it can be performed with 19 gauge needle with guide wire. However, at this time, with the hot system, so sometimes we don't need guide wire, we don't need 19 gauge needle, we just use the hot system. Anyway, some experts still prefer to use 19 gauge needle first with the guide wire in, even though the hot system, this is to ensure the track in some difficult case. The second step for dilation. Typically, endosonographers start dilation process with the coagulator. Then it can be followed by either serial dilator, for example, Schoendas dilator or balloon dilator. And the last step, we go to the stent placement. So for stent placement, techniques to deploy stent depends on types of the target organ and also depends on the type of the stent, including plastic stent, breech stent, lamps, and hepaticogastrostomy stent. Today I will cover the Spaxus, which is lumen opposing metal stent for stent deployment. For Spaxus, it has two systems. The first one is a cold system. For the cold system, the delivery system is 10 French, diameter of the delivery system. Length of the stent is about 2 centimeters in length. If you look at this image, which is very important, for the catheter, you will see the yellow marker, and the next one will be inner X-ray marker. The next one will be the blue marker, and the last one or the farthest one is outer X-ray marker. So for outer and inner X-ray marker, these can be seen by fluoroscopic image. But for blue marker and yellow marker, this can be seen under endoscopic image. So in step 1, when the outer X-ray markers overlap with the inner X-ray marker while you are deploying the stent, when the outer comes until overlap with the inner X-ray marker, at this point it meant that the distal phalanx is completely open. Then you will use the endoscopic view in step 2. When the blue marker is visible under the endoscopic view, you are ready to start opening proximal phalanx of the stent. For the hot system, difference from the cold system is at the tip of the distal phalanx. It has electrocautery tip, and this will be connected with the electrocautery enabled delivery system, which you will plug this to the electrocautery machine. You select the pad specifically by generator manufacturer and set the setting to pure cut mode 80 to 120 watts 400 to 500 volts and connect the plug to the electrosurgical unit with a compatible active care. And similar to the cold system, the hot system has blue marker, outer X-ray, inner X-ray marker, and yellow marker. So when the outer X-ray marker overlaps with the inner X-ray marker, it means that the distal phalanx is completely open. And when the blue marker is visible under endoscopic view, you can start opening of the proximal phalanx. This video demonstrates deployment of the Spaxus stent in model. Firstly, you unlock the stent. Secondly, you deploy the stent until outer X-ray marker go to the inner X-ray marker. After that, pull the stent, and with the endoscopic view, once you see the blue marker, you can continue deployment until the proximal phalanx is fully open and the blue color overlap with the yellow marker.
Okay.
So I'd like to show you one more time. Firstly, deploy the distal phalanx. Outer X-ray marker come to the inner X-ray marker. Once it's come, the distal phalanx is fully deployed. Then pull the stent back until using the endoscopic view, you can see the blue marker. And then continue deploying the stent. Until the blue marker overlap with the yellow marker. Then the distal phalanx fully open.
Okay.
EUS guided pancreatic fluid collection drainage with the cold Spaxus. This is created by one of my ex-fellow, Dr. Piyapum. In this patient, 56-year-old female with peripancreatitis came with abdominal pain. CT scan show large pancreatic fluid collection. We use the hot Spaxus when in. We use the cold Spaxus. So then we start with the 19 gauge needle with the guide wire in. And then we left the guide wire in the cavity. Here the guide wire is. After electrocautery dilator, dilation was performed with the hurricane balloon. Here the hurricane balloon is 4 mm. And then we deploy the distal phalanx until outer come to the inner marker. We pull the stent close to the wall of the pancreatic fluid collection and completely deploy the stent, similar to the technique that I just described. Here is another case created by Dr. Cherlermpol Bunmi, who is my ex-fellow. This is a case of EUS guided PFC drainage by the hot Spaxus. So this is a 63-year-old male with history of severe pancreatitis and large pancreatic fluid collection. So we schedule for EUS guided PFC drainage by the hot Spaxus. So we puncture and dilate the tract in the same time with the hot Spaxus. Once the hot Spaxus in, we deploy the distal flange, pull the stent back until the distal flange reach to the wall of the PFC. And we can see the blue marker with the endoscopic view. And then we continue deployment. And now it's fully deployed. This is the final fluoroscopic image of the fully deployed, and we dilate the stent with the balloon and use the gastroscope to do the direct endoscopic necrosectomy in this case. This is another interesting case. In this case, we have placed the first stent and it's been migrated into the PFC cavity. So then we have to help the patient by push the cold Spaxus. As a second lens. And finally, we can successfully place the cold Spaxus and we can retrieve the first migrated stent out. But during the procedure, when we remove the migrated stent, so the lamps that we just pressed also follow the migrated stent, as you see in this video. So then the second lamps also migrated out, and this is the first lamp that was in the pancreatic fluid collection. So then we come back, we see the fistula is still open. So then we use the third lamps and deploy under the endoscopic view. And you can see now that we use the gastroscopy, and the gastroscopy can also be used to deploy the stent. I'd like to show you one more time. You see the blue image here, right? This is a blue image. So once you see the blue image, you continue deployment, pulling back until the proximal flange fully open. So now we can deploy the third lamp for this patient under gastroscopy. And we can continue direct endoscopic necrosectomy procedure. This is another interesting technique. The video has been created by one of my ex-EUS fellow, Dr. Khan from Vietnam. So the patient has worn, and we have used lamps for successful direct endoscopic necrosectomy. Unfortunately, 2 weeks after that, the patient still has symptomatic worn. We don't want to continue lamps through the pancreatic from worn through the stomach longer than a couple weeks in our center. So then we decided to change lamps to the plastic stent, but just want to make sure that the plastic stent will be in place. So then we use double channel gastroscope. Before we remove the lamps, we insert the catheter with the guide wire into the worn cavity, and we use another channel using the rat-touche forceps to pull the lamps out. But catheter and the guide wire is still in the pancreatic fluid collection. As you see by this video, we still keep the track, and we use another channel to pull the lamps back, and then we insert the plastic stent across the lumen of the lamps. I like to see this, show this for one more time. Here we insert the stent through the lamps, and after that we can keep the track open. So we insert another guide wire and press another plastic stent. So this is another technique to ensure that we can keep the fistula open. The reason that we have to make sure that the plastic stent go deep, because the collection of this patient is very big. So if you see on the fluoroscopic view here, it go down very far. To make sure that both plastic stent go to the deep part of the wall, and then we can do the direct endoscopic necrosectomy later and safely.
Hello, yes. So I think we finished the video.
Fantastic presentation, Pradham. Very, very nice and real good practical tips for those who are going to use Spaxus now, and also good tips for those who are already using, so they can learn. So, Lazaro, any questions?
Yes, excellent lecture. Very, very excellent.
Thank you.
My first question is the migration frequency. Is frequent the migration with the Spaxus?
Migration.
Actually, very infrequent, very infrequent. And I think that if you learn the technique to deploy the stent properly, chance of the migration is very low.
Okay.
And today you will learn several times from various kinds of lamps. And I hope that after this lecture, I think we all agree that endosconographer who will perform this procedure will not make a migration happen again. I wish.
Thank you. What do you do with the post-procedure bleeding?
And the breathing?
With blood, with bleeding.
With breathing.
Yeah.
I mean, you mean breathing during the transmural puncture, or
Yes.
breathing inside the PFC?
Breathing inside the procedure.
During the procedure. Actually, at the beginning, before we start doing PFC drainage, we try hard to avoid intervening vessels, and then we don't want to cause the bleeding. But if it happens, sometime if it's not at that active and you don't have a particular point that you can provide a hemoclip or whatever to stop the bleeding, so then you can wait and see. But if the bleeding is still active, you will know within a few, maybe 30 minutes or 60 minutes, maybe we need some help from the interventional radiologist.
Thank you. Do you use always dilatation after stent placement?
Actually, I think this is another point for discussion today. And today, because of Vinay, we have several lecturers covering for all varieties of the lamps. So then I think that each lamps, they have different radial force. So then in the stronger, with the lamps with the higher radial force, probably you don't need to. But lamps with the, lower radial force, you might need to do that. But for me, personally, I do not dilate the track. After I don't dilate the lumen of the lamps, because I think that maybe one day later, it should be dilated and enough, except we have to do some purpose specifically. For example, we want to drain all the necrotic material, or we want to take the migrated stent from the PFC. So in that case, we might need to do the dilation immediately with the CRE balloon. But normally, I wouldn't do that. And if you do that, one thing that you have to be concerned, after you dilate the tract and then you try to push the gastroscope to do the necrosectomy immediately, sometimes the diameter of the lens is not well expanded. So then the gastroscope might bring the lens out incidentally. And that happened sometime in my unit, yes.
Good point.
Pratham, I have one question for you. If you have placed a Spaxus stent or any other LAMS, and you later on found out that this patient has a disconnected duct syndrome, so would you remove this stent and then keep a plastic stent inside, or would you just remove this stent and not do anything? What would be your...
That's a good question, and actually result from your study is very informative, and congratulate for that. So, in our unit, after we have successful drainage of the wound by either lens, plastic stent, or whatever, if possible, we try to do the pancreatogram either by the MRCP or by the ERP, because continuous leakage of the pancreatic duct to the pancreatic fluid collection is very important, and that might cause recurrent symptomatic pancreatic fluid collection again. So then if it happens, we try to fix by the transferability pancreatic stenting. But if there is no connection, certainly we can remove the cystogastrostomy stent. But if there is some continuous leakage from the main pancreatic duct, if we fail to fix that by transferability pancreatic stenting, then we need to keep the cystogastrostomy stent for good. And in that case, certainly we need to change from the metal stent to the plastic stent. Yes, this is my practice. Yeah,
use a plastic stent. Okay, okay. Moon, what do you do?
We need the keeping plastic stent after removal of Spaxus, definitely. Ways for disconnecting pancreatic duct syndrome, no choice.
I'm seeing you are back to the beach.
It's true. From now, I'm summer vacation.
Oh, because you done very hard work for this conference, Vinay. You have to pay for his trip.
Yes.
Okay, thanks, Pratham. Thanks, Moon. Thanks a lot. I think we should move on to the next lecture, and it's again a topic very close to my heart. Plastic stents. Somehow we are going too much metal, becoming Metallica, and we are forgetting plastic stents. And Professor Takao Itoi, a very good friend of ours, is here, who has developed a plastic stent. So let us hear from him how he got the idea of developing a plastic stent, and where does he use it, and what are the results. Takao.
Thank you, kind introductions, Binay. I'm also just in my summer holiday now. Okay. Again, thank you very much for having me here. So let's get started. My talk is on the dedicated plastic stent for interventional EUS. Okay, in the biliary stenting by means of ERCP, we commonly use the plastic stent and the metal stent. I think the selection of a stent depends on the case by case. For example, the malignant or benign, or temporary or permanent, or until die or long lasting. And recently the EUS guided biliary drainage is emerging. As you can see, there are mainly two access routes, namely the choledochogerostomy and the hepaticogastrostomy. In such cases, in the access route, metal stent is frequently used. we also frequently use the metal stent. And also, in terms of hepatic gastrostomy, we frequently use metal stent, and also we use a plastic stent. Even in EUS guided pancreatic duct drainage stenting, rarely, but we use a metal stent. Like here, very rare. Mostly we use a plastic stent because in the setting of benign restriction, usually, right? So since at the early stage of interventional EUS, plastic and metal stent were dedicated ERCP stent. So we have experienced sometimes the difficulty of stent placement by not only metal stent but also plastic stent. So what kind of stent is optimal? Anyway, so old one is dedicated, always or dedicated ERCP stent. So that's why. So I'm thinking of a newly dedicated stent for interventional EUS like this. So I'd like to show how to make a new plastic stent. First, how to come up with IT stent. What is optimal stent? I think more so good better application for benign disease. Removal is mandatory, and the pushability, trackability is also very important. And the easy placement. I mean, more tapered tip here, and no stent migration is also mandatory. And even though the drainage, the aim of stent is drain. That's why. So well drain is also a good thing, most important thing. And also minimum risk of bile or pancreatic juice is a very important point. So how to develop? So I cannot make a stent by myself. That's why. So let's make a new plastic stent with company.
Takao, if I can interrupt, sorry, there is a something blocking your slides. It's
Really?
Yeah.
You can see?
No, I can see the slide now, but when you make it full screen, there is a thing which is Apple. Maybe you'll have to reduce it. The red and there is something written in Japanese, and then there are some marks, color marks.
You can see?
I can see the slide, but there is something in front of it.
I think it's your font. You're writing your font, the color.
Color panel.
Color
Yes.
panel. Color panel. Yeah. So maybe you'll have to stop the color panel on your computer.
Color panel.
Yes.
Oh, I'm not sure. You can see
Do you want to try to stop sharing, and then maybe you can see?
anyway, you can see my slide.
There's
Yeah.
yes, we do, but there's a blocking. It's
Blocking.
whether you're.
Maybe you can take a photo. For
Oh, it's
us
gone
and
now. It's
send-
gone
send
now.
it.
Yeah,
Oh,
yeah.
it's here now.
No. But return again.
Just went and came back.
Oh, exactly. There's no desktop.
So the color panel window you will have to close.
List.
Yes.
Oh.
List.
Again it came back.
Okay, soon
Close
come back.
there.
Soon come back. Okay.
Yes.
Yeah.
Yes.
Okay, now. Okay.
Now share slides.
Thank you.
Thank you.
while we are waiting for Takao, hi Mark, welcome. Professor Giovannini is with us for the next lecture.
Yes. Hello.
Hello, Mark. Welcome.
Hello.
Hello, Dr. Giovannini.
Hello, Lazaro. Hello.
I'm fine. And you?
Very well. And you?
Yeah, very well. Thank you.
Takao has logged out, I think. He has to log in.
Vinay, maybe you use your phone, take a screen of Takao and send to him, and perhaps he will know what does it mean for the Apple one.
In the end, but I don't know, he logged out by mistake. I think he'll have to come back again. Sorry about this. These things happen, technical issues with slides and other things. So I'm sure Takao will resolve them and come back to us. In the meanwhile, if there are any more questions, let me find out. So, Pradam, there is a very simple question for you. Why you want to use a pigtail stent? Why not a straight stent through the metal stent?
Oh, I think it's absolutely better because it has pigtail both arms, so
Right.
prevent migration, right? Yeah, I think. Do you use a straight stent through the lamps?
The question from someone. So I always use a double pigtail like you.
And maybe I have a question for either Moon, you, that for the CDS, and that you use lamps, and then later on the lamps work very well, so then it's been there, patients still living very well. If you don't push the double pigtail plastic stent across the lumen of the lamp, any trouble of the recurrent cholangitis because of collapsing of the wall and hit to the one end of the lamps?
Yes, I agree with you totally. A plastic stent is very helpful in these situations.
Yeah. How about you, Moon? Yeah.
Yes, I agree. But so sometimes, but not always. Sometimes I put the double pigtail stent even through the CDS. But surprisingly, I never met that kind of blocking of the distal end of the Spaxus by the reducing of CBD diameter. Almost no problem of that kind of adverse event. So I recommend to the beginning doctors, even after Spaxus for CDS, put the double pigtail stent can make sure of the drainage. So I recommend to the beginning doctors, even
Yes.
CDS.
Yes.
Mark, you also use a plastic stent through LAMS for CDS?
Yeah. Yes. This prevent two complications, and then the first is as Professor Jung said, there is the occlusion by the contralateral wall of the CBD, but also the food impaction, because food impaction is the worst complication that we have with the lamps and CDS.
Yes.
I think lamps is very good for the CDS. And Vinay, do you still use tubular stent for CDS or totally change to the lamps?
Use tubular stent sometimes. So cost becomes an issue for us because lots of our patients are not insured. So we have to offer them various choices, and of course we tell them this is better, but sometimes because of cost issues we still use tubular stents for CDS also.
Yeah.
And
So
also in some conditions, sometimes the CBD is not so dilated. And mainly the patient has a huge gallbladder, and the CBD is not It's 10, 12 millimeter, and it's easier to insert a standard biliary, fully covered biliary stent than a lamps in this special condition.
Yeah. That's good comment, Mark. Thank you. Yeah, Moon, your slide presentation is very nice. You use the lamps for the CDS, and you insert the kaleidoscope through the lamps. That's very interesting. So, how big of the lamp that you use in that case, and how many days you left the lamp in place before pushing the kaleidoscope in?
For Spaxus, for CDS, we could introduce the kind of gastroscope actually immediately, or just 2 or 3 days later. It's different with HGS. So it can make a variform apposition. So you can introduce a gastroscope through the stent. But I wouldn't like to recommend using ultra slim scope, like a nasal scope, to inserting of scope. And still the movement of the tip of gastroscope is a little bit different inside the bile duct to reaching proximal portion, like over the hilum. So I think we need some modification of gastroscope for specialized intervention through the lamps in the future. So maybe you can ask a company and collaborate to develop the kind of maybe new types of scope for the intervention through the lamp.
Yeah. And what did you do after you already placed the CDS stent for drainage in malignant unresectable case? It's all done.
Yes.
What will you do for more with the kaleidoscope after that?
You know, the kind of like heavy infiltration of cancer distal CBD, we couldn't make tissue sampling. And after introduction of a scope to distal CBD, we could make a tissue biopsy and make a confirmation of malignancy. And also intentional removal of floating stones. So I have some cases of the removal of migrated some fragment of plastic stent or PTVD tube, and it's like my hobby.
Yeah, I know.
Okay, Takao is back. Takao, sorry for
Takao, hey, welcome.
Yeah. Oh, it's still there.
Yeah.
It's okay. It's okay. Let it be. The color screen.
Stent with the company. One company is a Galerius Medical company. As you can see, this is a regionally Swedish company. And now one the company in Japan. And we collaborate with this company, and we make a new stent. You can see this stent. Polyethylene materials is a common materials, not so special, not special. And outer taper tip here, outer taper tip, and so no stent migration because pigtail and two big branch, two both side big branch, and well drained because both end, of course, usually, and the pore aperture hole here, and 8 small pores, a pigtail portion, and around here, only 2 cm. And the minimum leakage of pancreatic juice or bile because no hole between the two both ends. And I'd like to show our outcome and the cases. So you can see animation, the plastic stent placement.
Yes.
After depiction of this dilated bile duct, intrahepatic bile duct, and the 19 gauge needle puncture, sometimes we use a 22 gauge needle, especially in benign disease because of small duct, non-dilated ducts frequently. And finally, IT stent placed. So you can see our outcome here. And at this moment, a very small number of cases. I'm very happy the technical and clinical success 100%, and the adverse event 3 cases with mild adverse event, and the occlusion rate 14%. Surprisingly, the 4 months patent and up to 9 months. I mean, occlusion rate is 19 cases, no occlusion until died. It is very important thing. And at this moment, there is no obvious difference between the plastic stent and metal stent in hepaticogastrostomy cases. Of course, including benign and malignant diseases, very mixed. You can see a case, this guided hepaticogastro or using dedicated stent. The targeted dilated duct here, not so dilation. So, fortunately, we got a small bile duct and the injection very nicely cholangiography obtained, and guide wire insertion. At this moment, all 2 1-inch guide wire, the Cook guide wire, insulation guide wire. That's why, so we can use cautery dilator at this moment and change the 0.25 5-inch guide wire bisagride, and after dilation, finally, plastic stent was placed. Very easy. And we thought that EUS HGS using dedicated stent sounds nice. However, clinically, in the setting of malignant distal bile duct stricture, we frequently use EUS guided anticoagulated stenting plus hepatocogastro. Because physiological bile flow, anticoagulated stenting is much better with large bore metal stent, like skimmer, and to keep the access route for reintervention, like this. So I'd like to show the movie as well. Very naturally dilated duct. Relatively easy case. Not so complicated case, and the distal biliary stricture. A long stricture and a guide wire in place in the duodenum, left in place. And after measuring the distance of the stricture and uncovered, usually we use the uncovered metal stent. Up to half portion, and to keep the access route and for the intervention, safety, and the plastic stent was placed. So you can see our outcome of EUS guided anticoagulated metal stenting with a hepatocogastro using IT stent. So our data here, we very satisfied our outcome on not only the technical clinical success and the adverse event, but also time to dysfunction. Here, the only 3 cases the occlusion until die, and the time to dysfunction date to 3 days, a long lasting patent. We are very happy to see. And in terms of medical cost, our technique may be more cost effective and more benefit. maybe a similar outcome to the metal stent with metal stent. And interestingly, so like this, but in case of a short prognosis, less than two months or 3 months, and US guided hepatic gastro alone, using a IT stent alone, is the more, I guess, the most cheap drainage cost. If plastic stent of hepatic gastro is patent until die, I think so. So, but some people, some endoscopists worried about the exchange of this stent. How to exchange with this stent alongside the guide, the stent, using catheter and the guide wire alongside the guide wire in place in the bile duct first, and left the guide wire in place, and using snare forceps. Sometimes the snare is very difficult. So anyway, so in this case, fortunately, the glass stent edge, and the guide wire right in place and remove through the scope easily, and also replace as well as the IT stent. Another case also, this is a very difficult position. Fortunately, alongside the stent, guide wire advance easily in the intrahepatic bile duct, and keeping the guide wire in the bile duct. And usually we use lat forceps to remove the stent, like this. Forceps, of course, some expertise of EUS or ERCP doctor maybe just remove the stent and put the guide wire is easy. But so for the beginner, the technique is very safe, I think. We can remove through the scope, keeping the guide wire in the bile duct in place. And you can see a USPD animation. Previously, I showed sometime using a guide wire, the pulse stricture side, as long as possible. And after dilation of the gastric wall and the parenchymal pancreas, also anastomosis. And finally, IT stent is placed. Of course, sometimes we use a balloon to dilate the anastomosis. Usually the 6 millimeter in diameter. And finally, across the stricture, we place a plastic stent, IT stent. So this is the first report. The number of cases very small, but relatively nice outcome. So after this, we use now the more than 60 cases using this stent. And intermittent analysis, you can see long-term clinical success rate is 92%. We are very comfortable for this the outcome. So I'd like to show the movie. So this is a dilated pancreatic duct. Looks at soft pancreas. In such cases, not so difficult to puncture, and the dilation of the pancreatic duct. After this is a failed ERCP cases. The guide wire in place as long as possible in the pancreatic duct. And after dilation, in case of USPD, we frequently use cautery dilator, but in this case is ES dilator, mechanical, very ultra tapered tip guide wire dilator to avoid unnecessary bleeding or perforation. And very easily, smoothly, they push and finish. Another case, very small duct. In this case, after post-whip patient and the pancreatic fistula is present. That's why so non-dilated pancreatic duct. Very small and a 22 gauge needle. Bounce in the pancreatic duct. Fortunately, the pancreatic ground was obtained as well as the 018 inch guide wire advance in the pancreatic duct. After dilation, this is not so hard pancreas, so just standard catheter is possible to advance in the pancreatic duct. And after that, exchange with 025 inch hard type Visigride and the dilation of the fistula. And finally, IT stent was placed. After this, the pancreatic fistula disappeared and the patient discharged. Happy, very happy. And in case of PD stent exchange, is very difficult comparing to the hepatocogastro because the scope tip is very flappy in the post-whip patient or something. That's why. But even though the expertise of ERCP may be possible, like bile duct cannulation and exchange the stent. So future, last but not least, this is the future direction. I think now we just made repositionable this stent, consolidated IT stent, the minimum step down tip, very easy to advance in the pancreatic duct or bile duct. Maybe coming soon in available in Japan. So I think future directions 3 point more cheap and effective. Cheaper is very important for the patient in some patient. Not always rich people in each country. And absorbable or expandable, I'm one thinking. And another one is a more easy selection or placement of stent. Or individual stent size or diameter or something is one of option. And the expanding ID stent to the world for a patient. First launch in end of this year, I guess in Taiwan. I hope we will distribute more and more in the world. Thank you so much. Thank you for your kind attention.
Thank you, Takao. Thanks a lot. Wonderful lecture as usual.
Okay.
So patients who cannot afford a metal stent, patients with malignant obstruction, you think this stent can be useful for drainage of bile duct? Do you have a data on how long does this stent remain patent? So,
Bile duct?
Yes.
Bile duct is so 4 months.
Oh, that's nice.
Yeah, that is very similar to the transpapillary plastic stenting. That's why, so in 3 or 4 months, prognosis patient is just put the IT stent.
Okay, and one more question. I'm sorry, we are running a little late. Suppose you put a routine, you know, the stents that are available in the market. Is there a difference in the leak rate? So you try to push a routine plastic stent and do an HGS versus an IT stent. I love the IT stent, of course, but just for people who have been asking this question, is there any difference? If you can explain why IT stent, I feel it is much better, easier to push. What would you say about this?
It is very important thing. So if we cannot use IT dedicated stent, we have no choice. But the tract dilation is the most important thing before stenting. That's why. So step by step. So if possible, the hurricane dilator or something the other the enough dilation. Then, so put a stenting.
Okay, so higher chances of problems, more steps.
Exactly.
Right. Thanks, Takao. Thanks a lot. Many
Thank you
more.
so much.
But
Thank you.
running late. Wonderful lecture. Thank you very much.
Very
so
nice. Very nice. Thanks.
So the next speaker is well known to everyone, Mark Giovannini. Pradam, please share. Mark.
Hello? Yeah. Do you hear me?
Yes.
Okay.
So
do you have my?
How you thought about Giobor and how the idea came? You really want to...
I will give you the answer on my presentation. I will show you also the history of the hepaticogastrostomy, because the idea of the Giobor stent is quite parallel to the development of the hepaticogastrostomy. This is the beginning of the story of the hepaticogastrostomy. This is a very old paper published by the radiologist. There was a French radiologist. His name was Soulez, and he for patients with advanced and palliative treatment of jaundice, he developed this idea to do an internal-external drainage of the liver, guided by PTBD, and also laparoscopically guided to do an endoscopically and laparoscopically guided to do this kind of montage with an internal drainage and also always an external access to the bile duct. And the goal is to allow to have an internal drainage and not to have an external drainage with all the complications that the external drainage occur. But this technique, it was very, very clever. But you see that even if the success rate was no bad, the morbidity of this technique was a little bit too high, and also it was not so easy to perform, because therefore to perform this hepaticogastrostomy using this radiology, you need a radiologist, you need a gastroenterologist, an endoscopist, and a surgeon to perform this technique. It's for this reason that this technique disappeared. At the end of the last century, this is probably my first case, my first hepaticogastrostomy that I performed. At this time, you see the scope 38 UX from Pentax with the 3.8 millimeter walking channel, but there is no elevator. And this is the first case that I performed. It was a patient with a huge pseudocystic dilatation of the bile duct, and the idea was to treat this dilatation of the bile duct like a pseudocyst, because I had performed a lot of pseudocyst drainage using this technique with this one-step device, and we perform this direct puncture of the dilated pseudocystic dilatation of the duct, and you see here the stent, the plastic stent in place, and this is the endoscopic view with the two stents inserted in the two the huge dilatation of this bile duct, and the patient went well during some week. And this is the first publication in endoscopy, and you see this was the case of a patient with a right hepatectomy for gastric cancer. The patient developed a recurrence. A first metallic stent was inserted by PTC, and the patient relapsed, and the patient refused to have a second PTBD procedure. And we decided together to try this new technique. And for this hepaticogastrostomy, we use a partially covered stent. And this stent will stay in place very well during 3 weeks. And after 3 weeks, the stent has partially migrated into the gastric wall. And this is the first video case in the world, I think, during a live demonstration of an hepaticogastrostomy. It was performed in Malaysia in the unit of Ryan. It was a case of patient with jaundice and duodenal involvement by a pancreatic cancer. It was not possible to reach the papilla with the duodenoscope, and we decided with Jacques Devière and Ryan to do an hepaticogastrostomy. But at this time, the problem was we don't have the small cystostome, and we will use also a partially covered stent. And you see the technique you know very well, the opacification, the insertion of the wire. But we use the 10 French cystostome, which is the first mistake, because the 10 French cystostome is too big, and even if in this case we succeed to insert the 10 French cystostome into the bile duct, the patient we succeed also to insert the partially covered stent, 8 centimeters. But the patient developed a bile leakage 1 week after due to the large puncturing dilation induced by the 10 French cystostome. And here you see the quality of the video is not very good because it's a very old video. And here you see the opening of this partially covered stent into the stomach. And also, if you see at this time, we leave not too much stent into the stomach. Alors why the idea of the Giobor stent is because you see on this slide that there is between the 2002 and 2015 a large number of series were published, and using plastic stent, using also a stent-in-stent technique, which is a technique using a first 10 centimeter uncovered stent, metallic stent, and inside this stent to prevent the bile leakage, we inserted a 6 centimeter fully covered stent. Partially covered stent, fully covered stent, but the main problem is that the fully covered stent have a high risk of migration and bile leakage. Plastic stent, we need to have to dilate the pancreatic tract, and also with a high risk of bile leakage. Partially covered stent and fully covered stent, there is obstruction of the side branch of the bile duct tree, and with high risk of cholangitis and liver abscess. All these data were reported on the paper of Michel Calalé in 2013. And just to show you, this is an image of an hepatocholangiocarcinoma drain endoscopically for the right lobe, and using a partially covered stent for the left lobe with using the EUS route. And here you see this paper of Michel Calalé, and you see that this series is interesting because for hepaticogastrostomy, in 67% of cases we use a metallic stent, and in 30% of case plastic stent. But the main problem you understand was the bead leakage. It was quite 10% of bead leakage, and also 12% of bleeding, mainly using this is due to the use of the pre-cutting catheter and not the cystostome to create the anastomosis between the left lobe, the left biliary lobe, and the stomach. This is all the paper published today using for hepaticogastrostomy. But if you see, this is all in all this paper, you have a case 1, 2, 3, 4, 5% of case of biliary leakage, and biliary leakage is really the worst complication during hepaticogastrostomy. How to solve this, and this is the idea to use this Giobor stent. This is the first generation of Giobor stent. It was 8 or 10 centimeter stent, half covered, and the uncovered part will be pushed inside the bile duct to prevent the migration, and the covered part was inserted through the gastric wall to prevent the bile leakage. And I had this idea because I saw the stent that the radiologists use for the portal hypertension, to do tips for the portal hypertension, is quite the same idea. Was one part is uncovered, one part is covered to achieve the treatment of the portal hypertension. But why the name Giobor? Why? Because Gio is the beginning of my name. Bor is the beginning of the name of my collaborator at this moment, Erwan Bori. And here you see the draw, the first draw that we gave to the Taiwan company to perform this stent. What are the advantages of the Giobor stent? Is that the uncovered part prevents the migration and the obstruction of the side branch of the bile duct. The covered part will prevent the bile leakage. The large flare try to prevent the migration, and also it's easy to clean when obstruction. And here you see you have this obstructed hepaticogastrostomy, and it's using a gastroscope, a thin gastroscope. Is easy to clean with a balloon and to go quite inside the liver, and after to leave another stent inside. That this is one of the main advantage of the hepaticogastrostomy. This is our paper published now 3 years ago, and we have evaluated prospectively 41 patients. In which there were an indication of hepaticogastrostomy. And you see that in this 31 patients, there is no bile leakage reported. We have a cholangitis due to the obstruction of the stent, or sometimes the cover part was too inserted inside the bile duct, and they covered some side branch. Obstruction, and one case of migration with, of course, a bile leakage, but migration occur only in one of these 41 patients. The second generation of Giobor is a little bit different because there is a Japanese study that evaluated the length of the uncovered parts. And probably 50% it was a little bit too much, because we need probably to reduce the risk of bile leakage. You need to have a long covered part. And this paper has evaluated 1, 2, and 3 centimeters of uncovered parts, and the best results are obtained with the 3 centimeter uncovered for the 10 centimeter stent. And you see this image with the large flange, and the flange was larger than the first generation to prevent again the risk of migration. This is one case of Giobor insertion of the new generation. It was a patient with cholangitis and obstruction of a previous biliary stent in place. It was not possible to reach again the papilla due to a duodenal involvement, and you see that there is some aerobilia with pus floating in bile duct. Bile ducts are not so dilated, and of course we use the 19 gauge needle to perform the puncture of the stent. I always aspirate. This is a small trick before to inject, to be sure that the tip of the needle is inside the bile duct. Because if you are not sure if you inject, you will have a very large hyperechoic area, and you will miss the target after. And it's for this reason that I always aspirate before to inject contrast. Here you see the contrast inside the bile duct, the insertion of the wire, and after I think it's very important to use the 6 French cystostom. For us is the main accessories, because with this cystostom there is no need to dilate the puncturing tract for the insertion of the stent. Also you can inject by the cystostom to be sure that the cystostom is in a good position. Here you see and the cystostom, and after we push the new Giobor stent, here you see no need to dilate the tract, and you have 2 markers. This first mark here is the junction between the uncovered part and the covered part, and this marker should be 1 centimeter above the puncturing tract at the level of the bile duct, and to be sure that if you push too much the stent inside, you have the risk to cover some side branch like this, and this can induce not every time, but you can induce some hepatic abscess. And this is the endoscopic image. Now, the second trick is to open the stent inside the working channel, like for the lamps, and this also prevents the risk of migration or during the deployment of the stent. To open inside the working channel to maintain with the elevator the stent. Here now we push the scope with the catheter, and this is the good size to have 3 or 4 centimeter of stent inside the stomach. And after I leave here in place a double pigtail stent to prevent even the migration or a nasocystic drain. Also to in case of a patient with a risk of migration, and here you see this pigtail stent inserted like this. This is a security. These stents are very important because they have changed the treatment of patients with complex biliary stenosis. And like this is a young woman with central metastasis from an ovarian cancer. Chemotherapy was not possible because the patient has had jaundice, and we decided to do this complex drainage. It was a type 4 of the Bismuth classification. We have inserted 2 stents endoscopically and 2 hepaticogastrostomy because the 2 segment 2 and segment 3 were separated. And this patient is still alive 8 years after the insertion of this 2 hepaticogastrostomy. she achieved a complete response at the chemotherapy. And now the big problem of this patient is the recurrence of cholangitis due to the obstruction of the stent. Also, for this patient with a complex cholangiocarcinoma, we have drained all the segment endoscopically and with the EUS route in 2 sessions. And the goal is to have a complete drainage of the liver and to start the chemotherapy or radiochemotherapy. It's very important to have a complete drainage because this increase the survival rate of the patient, and also during the chemotherapy, the complete drainage can prevent some complication like cholangitis or hepatic abscess in case of if 1 or 2 segments of the liver are not drained. What is the future? The future, this is one of my last slides. The future is always to be focused on the bile leakage, is to prevent the bile leakage. I think the first thing is the best selection of the patient. We need to discuss a patient with ascites. What is the outcome of the patient? What is the stage of the tumor, and so on and so on. I think it's very, very important to have a best selection of the patient. For us, the cystostome of 6 French is the best device to create the anastomosis between the bile duct and the stomach. And the new design of the Giobor stent should be, and I hope this could be possible in the near future, to combine the Giobor stent and the Spaxus stent like this, and 10 centimeter long stent, 3 centimeter uncovered, 7 centimeter covered, with the head of the Spaxus to prevent the migration. Of course, a hot system. This is the main interest to have the hot system, is to reduce the number of manipulation. With this kind of stent, if it's possible, the hepaticogastrostomy will reduce at 2 steps: the insertion of the wire first, and the second, the insertion of the stent with the cottering part here included in the delivery system of the stent. Thank you very much for your attention, and if you are interesting, we organize a EUS endo this year due to the COVID pandemic, 17-18 September, and the live case will be sent from my unit into the web with some famous experts like Jacques Devière, Guido Costamagna, and Nagi Reddy in Marseille. Thank you very much for your attention.
Thank you, Mark. Thank you very much. That was a wonderful lecture. Really, really enjoyed how it began, how difficult it was, and the future looks exciting. Future really looks exciting. Pradam, will you take over and ask some questions? Any audience questions or anything? We can't hear you. Put on your mic.
Yeah. Microphone, Prader, your microphone is not open.
So, before Pradam, is your microphone on? Not yet on. Please unmute. Yeah. Can't hear you. No.
No.
Mark, this combination of Spaxus with Giobor is very, very interesting. And
I hope that the Taiwan company will. This is an old idea that I try to push the Taiwan company to try to work on this. I know that it's probably not easy to insert everything into the stent, but I think the main problem of the hepaticogastrostomy sometimes is today we have too much manipulation. The wire, the dilation, the stent, and I think we need to reduce, like like the insertion of the lamps. You need to reduce the number of steps, and the reduction of the number of steps will increase the safety of the procedure. I'm quite sure. And I hope that people from Taiwan company are connected today and to push this idea.
Mark, Professor Moon,
Yeah.
You did show a case of a Spaxus HGS. What do you think of the idea of combining Spaxus with a Giobor?
Yes, I already showed the case. It's a similar concept we suggested by Gio, like a Gio stent modification. And so we have been developed the kind of stent more than 3 years ago. So now the kind of stent is just approved in Korean FDA. So now we are using it.
Oh, fantastic, fantastic.
Can you hear me now?
Yes, yes.
Oh, Mark, congratulations. Thank you very much. I always love my lecture. And
thank you.
Yeah, your Giobor stent done a lot for the world. Yes. And actually, I have used many of Giobor stent for my patients. And I feel like the problem of the migration back to the stomach is very low. That's because of the wonderful uncovered portion in the intrahepatic bile duct. This is in opposite with the fully covered stent, right? Yeah. And also the inward migration is also very low. I think because also because of the uncovered portion. So then what's the benefit of adding on the Spaxus to prevent the migration? What's the benefit of that?
The benefit is could be sometimes you have a migration is during the insertion of the stent. In some I think in some less experienced endoscopists, there are tendency to push to maintain too much the stent inside the working channel, and the stent has a tendency to go inside the duct and the peritoneum, and also this will prevent this kind of miss insertion, and also the main advantage of this we can probably use in patients with ascites. Because yes, I see this. But unfortunately, we don't have the in Europe. And I saw your and this could be also useful in patients with ascites, because the stent will be very well anchored into the stomach with no risk of migration into the peritoneum.
Yeah,
probably.
Yeah.
Thanks, Mark. This was wonderful.
Yeah. I saw. Thank you, Professor Moon.
Thank you. And we'll move on to the next lecture by Professor Miranda, who is going to tell us how to place a Giobor stent appropriately. Manolo.
Hey, welcome, Miranda. Hi.
Hi, can you hear me? I'm not if I'm silent.
Yes, I hear you very well in Thailand.
Okay.
Yeah.
That's great. Next, let's my slides. Can you see my slide?
We can see a lizard back behind. A green lizard.
You can see.
Cannot see your slide.
Oh, you can see, but you cannot see the slide. Maybe I'm doing something wrong. Sorry about this. Okay, I'm trying to.
Yes.
Okay.
Okay. Yes, we can see your slide now.
Good. Oh, I did it wrong. Sorry, I should have. Okay. Hey. So before I start, let me just say this is a real honor to be here at this webinar with the father of all these wonderful stents that we love and make our life easier, with Mark Giovannini It's not only the father of Giobor, it's also my father in interventional EUS, because I trained with him. So I'm sorry there is some overlap with Mark's lecture, but it's only natural that the sons take after the father. And also Dr. Binmoeller, Dr. Takao Itoi from Nagi. And I'm trying to be very practical, show you some videos, but before we get into the videos, this is the ideal features that we all, I think, we all like to have in a transmural USBD stent. A stent that's easy to place, and placement for a metal stent implies insertion into the target and then deployment. And then the second feature is that the stent is stable. Once it is placed, it stays in place. There is no leakage, no foreshortening, and no blockage. This is related to not only short-term adverse events like leakage, peritonitis, but also long-term patency. So ideally, we would like to avoid long-term issues with ingrowth or reflux cholangiosis or dysfunction of any origin. And then we would like to have a stent that's very easy to revise. In case the patient has any stent dysfunction, we can easily go through the stent and do whatever needs to be done. And especially in the case of benign disease that is still a developing indication for hepaticogastrostomy, there are only preliminary data. We like not only the ability to do intervention through the stent, but also easy removal. So traditionally, we had the standard metal biliary stents, either fully or partially covered. So this is a partially covered wall stent, one of the earlier versions. And you see the uncovered part is only 5 millimeters on the inner into the liver side and 5 millimeter in the gastric side. So in a way, the ID Giobor stent really, why use the uncovered, covered, symmetrical but useless design and not change it into a more specific for hepaticogastrostomy? And this is the concept of the modified self-expandable metal stents. The Giobor designed by Dr. Giovannini is the first one. And as you have seen from his lecture, nowadays the inner part that goes into the liver is uncovered. Now is 30%, and the 70% going proximal in stomach is fully. So anchoring is provided with the uncovered part, and leakage is prevented with the covered part. I would like to say that that design, or specifically hepaticogastrostomy stent, is not, the Giobor is not the only one. There are also similar ideas and similar concepts, and inward anchoring part, anti-migration gastric part, also sometimes coupled with dedicated introducing catheters. This is another interesting design that's also commercially available in Europe. There is this dilating piece at the tip of the delivery catheter. There is anti-migration features, and some studies from Korea. We see not only this dedicated stent is a small study, very small patient number, 16 on each arm, comparing this dedicated stent with a standard fully covered. But you see that even if the patient number is very small, the incidence of adverse events, early adverse events, is only 6% with this specific design stents versus 31% with the conventional design. Also very interestingly, the procedure time with a dedicated stent is 10 minutes, ranging from 5 to 12. And with a conventional stent, the same operators had a procedure time medium of 15 minutes, between 10 and 17. These are all very expert practitioners, very expert operators, and the procedure time is measured not from the mouth in to mouth out, but from puncture to stent deployment, right? So what's the most important feature, the most important adverse event that we want to prevent? Measure. This is what we want to happen. We don't want the stent migrating from the stomach into the peritoneal cavity right after deployment and causing severe peritonitis. And this, of course, this happens with standard biliary metal stents that don't incorporate any anti-migration features. This is the first reported case 10 years ago by Martins. This is another of Mark's children in Brazil, and he was honest enough to publish this complication. You see the stent going beyond the gastric wall into the peritoneum, causing severe peritonitis in a patient with unresectable malignancy. This was fatal. But you see the reason why this happens. You can appreciate in this endoscopic image. This is a partially covered wall stent. So it's only 5 millimeters here. And what you see, this stent foreshortens up to 30%. So the stent was originally placed into the stomach immediately after deployment, but you see here some tenting. This is, the gastric wall is coming away from the liver surface. And this stent, when it's going to expand, it's going to foreshorten. And that's the reason we call this migration, I don't know, but this is not really migration. This is foreshortening of a stent that was probably too short. And this is the things that we learned from the hard way when we started doing these things. So my question, I ask myself, is the Giobor anti-migration flap inside the stomach strong enough to prevent this phenomenon? I would say maybe, but maybe not. So the best prevention from inward migration is leaving, as Mark has also said in his talk, leaving a very long intragastric segment, maybe minimum 3 centimeters, 3-4 centimeters, especially if you are in the earlier phases of your experience. And as we know from studies coming from the United States and Korea, the learning curve for hepatogastrostomy involves between 30 and 40 cases. So it means we are all beginners for a long time because hepatogastrostomy is not such a common procedure. So this is, to be honest, and I told Dr. Dhir that I would say this, I've been not using the Giobor a lot. I've been using similar stents. So I asked Teoh company to let me have 2 stents so that I could produce videos for this lecture. This is one case that was done July the 31st in our unit. This is a patient with a Roux-en-Y gastrectomy for peptic ulcer disease, now develops biliary obstruction. You see the EUS guided cholangiogram. And this is one of the features that I would like to point out as a good for a Giobor stent. You see the peripheral bile duct is not very much dilated on the left side, which is in a Roux-en-Y patient is the only access that we have for a hilar stricture. We cannot go to the CBD, we cannot go to the right side, which is a little bit more dilated than the left. So the peripheral left is not dilated. We have to go very close to the confluence. We have to go hilar. And if we use a stent that is not uncovered, we're gonna block off main branches of the left side, or we have to leave the stent too short inside the bile duct, risking migration to the stomach. So I like this case. It just happened to come through the door 2 weeks ago when I was working and not on vacation, to show, look, this is very good to have an uncovered segment here. Now I'm going to play the video that Dr. Sanchez Ocaña edited for me. So we get the cholangiogram. The next thing, we want to have as much wire as possible. The wire here is coiling back above the stricture, and you see there is some distance because the peripheral bile duct was not very dilated. As Mark Giovannini said, we like to dilate because otherwise we're going to have trouble in passing the stent. We use the 6 French cystotome, and in addition to that, we like to use a balloon. During dilation, this is what I want to stress. We keep the guide wire into view. In our case, as the operator is looking at the fluoroscopy, an assistant is holding the scope and looking at the ultrasound so that he or she keeps the wire into view at all times. So once we have the cystotome in place, this is the case here, we can change the wire for a 35 wire. We like to use a 25 VisiGlide, and we balloon dilate twice. Once bile duct to liver and then liver to stomach. So sometimes even if the distance is less than 4 centimeters and we use a 4 centimeter balloon, to make sure we dilate at both points, we used to dilate twice. We aspirate to prevent leakage. We advance under EUS and under fluoroscopy. I see this angle. We have the mark. I'm going to go back because this is important. We have the radio opaque marker here. So we know this is all uncovered, and there's no problem that this stays inside the bile duct. There's not gonna be blockage of main side branches because this is all uncovered. And as we deploy, we keep track of the stent position. Sometimes we need to reposition backwards towards the endoscope. I forgot to mention, Mark already did, that we always to be on the safe side, we need to use at least 8 centimeter long. And if you are beginning, you need to use a 10 centimeter long stent, because you see there are 3 centimeters inside the bile duct, 3 centimeters across in the liver, maybe 1 centimeter in no man's land between the liver and the stomach, and then 3 plus 3 is 6, 7. You also like to have 3 nice centimeters inside the stomach. So even if your measured distance across the liver is maximum of 3 centimeters, 10 centimeters is okay. It's probably safer to err on the on the extra length side than on the too short. So sorry, I'm going back. Cystotome, balloon dilate twice, choose an 8 or 10 centimeter, and then when you deploy, you need to reposition towards your endoscope, and there are 2 choices. One is intra-channel stent release. If you're looking at the fluoro and you have a 10 centimeter stent, you are sure that you have only 6 centimeter, or then you can push backwards, insufflate, and deploy. And as you see, this is super long. This is 10 centimeter, 3 in the inside the bile duct, 3 to 4 across the liver and the stomach, and 3 in the stomach. And this is the way you are not going to get into any trouble. So this is what the video that I've shown you, I call the Giobor standard placement. So to summarize the practical tips, with the Giobor, the uncovered intrahepatic end gives you the benefit of not having to select a particularly peripheral intrahepatic bile duct branch, which if you use a fully covered, you have to be more careful to choose. So that gives you more options. Then the guide wire, to avoid friction, as I said, a 0.25-inch guide wire is probably better than a 0.35, and you have to make it either go to the right side, go antegradely across the hilar stricture, in the case I've shown you, or at least coil backwards into the dilated liver segment so that it gives you stability. Don't be afraid to dilate generously. We also customarily use the 6 French cystotome, but we additionally use the 4mm balloon to prevent leakage. What we do is during balloon exchange for the stent delivery catheter, we apply suction all the time to try to get the minimal leakage that happens into the working channel. Then choose a long Giobor stent. I would say minimum will be 8, and try to leave a long intragastric segment, minimum 3 centimeters, because sometimes this is not like colonic stenting, esophageal stenting, or even transpapillary biliary stenting at ERCP. Here, 1 centimeter longer or shorter can be a whole lot different. So length matters a lot, and it's better to be slightly longer than slightly shorter. So for the deployment, as I've shown you, we use ultrasound to monitor stent deployment, stent introducing, but also very important to keep your fluoro landmarks, especially the radiopaque markers, to avoid the phenomenon that Mark warned us about, that the stent goes inside very rapidly. If you only keep your eye on the EUS, like you might do with Spaxus, a Nagi, or an Axios stent, if you only keep your eye on EUS and you disregard fluoro, the stent may go inward into the liver unnoticed, and you cannot fix it. So intra-channel deployment has been suggested by Ogura from Osaka as a way to minimize that virtual space that happens between the liver and the stomach, the so-called candy sign. But sometimes the candy sign happens even if you are aiming for intra-channel. And this is what I'm going to show you in the next video. I've shown you an uneventful deployment, an eventful Giobor stent placement. And this is what I call Giobor placement with adjustment. And this is the second case I did. So it was shortly after July the 31st. In theory, I am an expert. And look at what happened here. So, I mean, I've done more than 40, which is the learning curve. Again, this is a very similar case. You see not much of a peripheral dilation on the left side. I don't know why, but sometimes these patients have a more dilation in the right side. We could see these very nice, these main bile duct. Use 19 gauge needle, get a cholangiogram, see the stricture. We are getting a 25 wire, some trouble getting to loop. We balloon dilate after cystotome passage twice. After we deflate the balloon, we apply suction. So this fluid from the obstructive bile duct goes along the wire into the channel. We deploy distal end until the mark, so the radiopaque markings are within limits. So we know this is only 3 centimeters. We try to do intra-channel. We track the stent deployment. We see the marker. Look, this is too short. We were aiming for 3 centimeters into the stomach, and is barely 2 centimeters here. And look at this nice candy sign that we were hoping to avoid. The second trouble that we come across is the proximal or intragastric end is not opening immediately as it happened in the previous case. So how do we deal with this? What we do is we balloon dilate the stent to see if there is any foreshortening, and if that foreshortening happens, we make it happen right in front of our eyes. So we place the 8mm balloon dilator. The second strategy that we use is we place a double pigtail. This is 7 French. Of course, if you have the single pigtail, it's much easier to insert. You can cut the first pigtail. And the fourth anchoring strategy that we use, or the third, sorry, is clipping. So we clip. This clip is not going to last forever, but we hope that at least it lasts until a mature fistula is created. Because if we revise, when we revise these patients, like 2-3 months down the road, if the patient is doing well under palliative chemotherapy and he survives, and there is some stent dysfunction, when we look at the clip has fallen off from the gastric mucosa, but at least this does not happen immediately. So this is our 3 extra anchoring strategies. One is balloon dilation to control for any foreshortening. The second is to use a long, this is 10 centimeter, 7 French double pigtail. The inner liver pigtail anchors inside, and in case there is any ingrowth here, this is going to help us find the ingrown lumen of the bile duct and the clipping. So I didn't mean to do this on purpose for this lecture. It just happened. I was trying to show like a nice and eventful placement, and this happened. So what I'll call my tips, my additional tips or precautions for the Giobor, as for any stent. I would say there is no perfect stent. There is no yet a foolproof stent. Of course, if you are doing EUS, that means you are not a fool. You are a physician. You are a trained endoscopist. But you cannot rely blindly that all these built-in automatisms, whatever the name of the stent, I don't want to give any names, but you know this is going to work always perfect. You have to keep at the back of your mind always like an alarm, an alertness of anything might go wrong, and it's not the stent's responsibility to make it safe. It is your responsibility. So whatever the stent you use, and I would say this also applies to the Giobor, but to any other EUS BD stent, the level of alertness has to be a little bit higher than when placing a stent in the colon, intraluminally, in the esophagus, or in the duodenum. The extra anchoring maneuvers that I shown in this video, immediate balloon dilation to control for foreshortening, a coaxial double pigtail, longer than the original Giobor in this case, and then clipping to the gastric wall. So I summarize ideal features of transmural EUS-BD stent and my opinion on how they apply to the Giobor stent. Easy placement for the Giobor stent. I would say it's average. It's not super easy because there is no built-in cautery system or a stiff dilator. Maybe, as Mark suggested, this is coming in the future, an average deployment. So it's good enough, it's not perfect. So how stable is the stent once it is properly placed? I think this is above average because the migration out from the liver into the stomach, outward migration is prevented by the uncovered part. I would say the flanges in the stomach are not perfect. The gastric wall can, patient can retch or the stomachs move. So you need to rely on extra stent length, not rely. It's a nice feature to have. About the long-term patency, I'm not sure about the ingrowth that was reported in Mark's series in US, that they had some instances of stent ingrowth. Of course, this is the trade-off, the price you have to pay to prevent acute leakage, which is a worse complication than delayed stent dysfunction. I would say this can be easily managed in most of the instances by placing another stent inside. If the stent is too long, maybe you can cut it with APC. So I would say that revision for malignant patients is relatively simple with the Giobor stent. It does allow through the stent intervention for malignant patients. I will show you the last example before my talk is finished. What I'm not sure, I have no experience, I would say removal is not easy. It's not impossible. I would say that you can place stent in stent to do away with ingrowth and try removal, but it's not a stent that I would use for benign disease. However, sometimes, not only this is an example of through the stent cholangioscopy for retroflex. See,
So,
yes?
We are running very, very late. So if you can.
Okay, I finished now. I finished. Yeah, that was my last slide. This is from the same patient, the cholangioscopy. The oncologist was not happy about our presumed diagnosis of malignancy. We didn't see any mass on EUS. And through this Giobor stent, we can nicely place so this is the tips that I've told you about. Especially, I would say, long length is the most easy to remember and the most important tip. So thank you very much for your attention.
Thank you, thank you, thank you, Manolo. That was a wonderful, wonderful, exhaustive lecture on technique.
Thank you, thank you.
You're welcome. My pleasure.
Told us, you know, the warnings and the other things. Thank you very much for that. Unfortunately, we can't take any questions because we are running late. So thanks again. Thanks a lot.
You're welcome. It's my pleasure to be here.
Yeah, and thank you. You came cutting your vacation short, I think, by 20 minutes.
No, I'm still on vacation. Look at the background. This is beautiful Mallorca. I just had I hired a cruise, so we were cruising on a boat today, but I was in time just to listen to Mark's lecture. And so I'm sorry I missed the previous speaker. You made me confess what I was doing. So I'm very close. I'm very close to Marseille, only 200 miles south of Marseille.
Thank you. Is Ken here? Kenneth Binmoeller? Should we start the next?
I am. Can you hear me?
Yes, Ken. Hi.
Yes,
We
yes.
can't see you, but of course we can see you now. So let's change track and go to Axios. And who better to tell us about how the idea of Axios came about and how the Axios stent was developed than Kenneth Binmoeller himself. Ken, we are privileged to have you here. Please continue.
Good. Let me see. Can you see my screen right now?
Yes.
Just okay. Perfect. Let me go to. Good. And now you've got the slide full screen.
Yes.
Yes. Perfect. Perfect. All right. Good. So
coming in color view. I don't know what is that. The color panel. Can you remove it from the screen?
Color panel.
Yeah, we are seeing a color. We had the same problem in Takao's presentation also.
Okay. I'm not sure. Let me see. I've got an IT guy here who maybe can help. June, are you here? I'm not sure what that color panel is.
Okay, you are not seeing it.
I'm not seeing it, no.
Continue then, let's see.
All right, so hopefully you can see the entire slide.
Yes.
All right, good. So firstly, Vinay, thank you very much for the invitation to contribute to this. I think this is an inaugural, a premiere in terms of a seminar dedicated to EUS stents. Stents that are specifically designed for EUS interventions. And I think that has been such a major breakthrough that we have seen over this past decade. And so we're, of course, going to see so many new and future breakthroughs in this space. But I feel very privileged to be part of the momentum of this new frontier. So my thanks for the invitation. And I'm going to actually take you on maybe a personal journey here in terms of the idea of the LAMS and how it was developed, and comment on future directions. Okay, let's see. There we go. You know, our partnership with industry is so critical for the advancement of our specialty, interventional endoscopy. But it's important that, of course, we are always transparent about conflicts of interest. So I am a proud parent of Axios, and Boston Scientific became the adoptive parent for Axios after Exlumina handed it over to them. But I don't have any royalty or equity stake in Axios. So I just want to be clear that I'm entirely neutral And I am interested solely as a practitioner to see our field advance, no matter who we work in partnership with. Much of my talk is in a chapter that I wrote or a contribution that I made for an inaugural issue of Techniques and Innovations in Gastrointestinal Endoscopy. It's a journal of the AGA, and Anthony Teoh invited me to contribute this first inaugural issue chapter, and Anthony is the co-editor for this first issue. So the title of this paper is Design Considerations of the Axios Stent and Electrocautery Enhanced Delivery System. So if you're interested, feel free to look at this article, which captures much of what you will hear about in my presentation. So I've been really blessed to have personally witnessed the evolution of EUS, starting as a pure imaging modality with using the radial scanning echo endoscope. That's how I started doing EUS when I joined NIPSA Hender's unit in 1991. And it evolved very quickly to an interventional modality with the ability to do FNA. And the therapy, our ability to do EUS-guided therapeutic interventions, that's of course where all the excitement is. And of course, this is thanks to the development of the linear array echo endoscope. So therapy started for me, because I think of FNA really as still an extension of diagnosis. So therapy started in Hamburg in 1992. We had a patient with a non-bulging pseudocyst. We were draining pseudocysts endoscopically, but we could only drain the bulging pseudocyst. And we had a patient with a non-bulging pseudocyst, and we started thinking outside the box in terms of how we might be able to drain this pseudocyst under EUS guidance. And we fortunately had one of the very first prototypes of the Pentax echo endoscope, the CLA echo endoscope with a 2.0 millimeter channel. So we punctured this pseudocyst with a home-fashioned device, really, and we passed a wire through it. We needed cautery to get into the pseudocyst, and then we did an over-the-wire exchange for the 4.2 millimeter duodenoscope. And from here, it's basically like ERCP. We dilated the tract, and then we placed a 10 French pigtail stent. And so that was the first report of EUS-guided drainage of a pancreatic pseudocyst in 1992, published in GIE. So we adopted from our radiology colleagues the Sondinger technique. It's the over-the-wire technique. And you're all familiar with this because this is how we had been draining pseudocysts. Historically, we access the cyst with an FNA needle. We insert a wire into the cyst, allow it to coil a few times. Now we have a platform to railroad our coaxial instruments over the guide wire. We dilate the tract. We can use a balloon. We can use a bougie. And then we drain the cysts with one or more plastic stents. But we soon realized that we endoscopists encountered challenges that our radiology colleagues really did not face, to the same degree at least, because we're working from a much further distance from our target. So we were performing multiple over-the-wire device exchanges, and in that process, we could lose access to our wire. And this was very tedious and time-consuming, working over this long distance. But more importantly, there was always a step-off between the guide wire and the catheter device. And this step-off created difficulties for us to traverse the wall, the bowel wall, and get into the target lumen, especially when that wall was fibrotic, as it is, for example, for a pseudocyst. And we realized that the Sondinger technique, as elegant and revolutionary as it was, it is a multi-step technique in which, with each of these steps, we take a risk. And that risk starts with the removal of our needle, leaving our guide wire in place. Because when we remove that needle, leaving the guide wire, we now have a gap between the guide wire and our tract. And this is where the leak actually starts, just with the removal of our FNA needle. When we dilate our tract to enable insertion of our stent later, we can displace our target lumen if it's not firmly adherent to the bowel wall. And this dilation itself can result even in perforation, into frank perforation. When we remove our dilator, again, we have that gap between the guide wire and our dilator, resulting in leak. And even when we place our stent, if it's not an adherent target lumen, we can displace that lumen away. And without question, the greatest fear was that we would cause perforation, frank perforation with leakage of intestinal contents into the peritoneal space. We also realized that there are many technical challenges using our conventional tubular stents for transluminal drainage. So these tubular stents have a tubular configuration. After all, they are designed for lumen recanalization. There's no lumen to lumen apposition. The ends project into both of the lumens. When we use plastic stents, the double pigtail stents, these have a small fixed diameter, so there can be leak around the stent itself. There is that gap between the stent and the tract diameter. If we place multiple stents, we have to place multiple guide wires, and this entails multiple steps. When we use metal stents, we address the problem of reducing the risk of leak with the covered SEMs, but we then realized we have the risk of mal-deployment and migration because these metal stents are tubular in configuration. Perhaps just totally captured in our enthusiasm that we could go through the bowel wall and we could access extraintestinal structures, we didn't fully realize that every time we do a transluminal intervention, we are creating an intentional perforation. So we get away with that with impunity when that target lesion is adherent to the bowel wall. But if it's not adherent, so for example, the gallbladder here, and you can see this echogenic layer interposed between the gallbladder and the bowel lumen, the duodenum, this gallbladder is not adherent. This is fat tissue between these two lumen structures. And when the patient goes to surgery, we again see that open space between the two lumens of the gallbladder and the duodenum. So what we have lacked are the tools dedicated for transluminal therapy, because all of our innovation has been in the lumen, and now we're thinking outside the lumen or through the wall with EUS guidance. We were this plumber here who is using his finger to plug the hole in the bathtub, and his wrench in the back pocket here isn't going to do a lot. And I was perhaps this child here who is asking, where are your tools? Because we need tools to prevent that risk of leak and perforation that sometimes could be even fatal. So we needed, in my opinion, two tools. Firstly, we needed a transluminal stent, what we today call a LAMS. It needs to be covered and self-expanding to seal off the tract, should be lumen opposing, and it should provide a port for transluminal intervention. This port for transluminal intervention is so critical if we truly want to extend the reach of the endoscopist to the extraintestinal space. But we also need a transluminal stent delivery system that is designed to eliminate Seldinger, to eliminate over the guide wire exchange. We need to be able to access the target lumen with a stent-loaded catheter. So here you can see some diagrams of some of the concepts which I patented very early on as I thought about ways that we can accomplish safer and more efficient transluminal therapy. So the LAMS concept was filed in 2008. This is from the abstract, a device whereby two luminal structures in the body may be drawn toward each other and a fluid conduit formed in between. Here you can see one of the embodiments that I came up with. It looks different from the Axios, of course, but the concept is shown here, how the two flanges are pulling the walls of these two lumens in apposition and holding them together. So this evolved to the Axios lambs with 4 key features. It consists of a self-expanding nitinol mesh. It has anchoring double-walled flanges. It has a very short 1 centimeter saddle that's designed to traverse just the 2 walls, and it has full silicone coating. Now, a parent, of course, spends a lot of time thinking about a great name for its newborn. So I thought a long time about a name that captures the spirit and the essence of the lambs. So I came up with the name Axios, which captures 2 things. First of all, it's axial introduction, which is how we work endoscopically, and it is creating an anastomosis, an ostomy. So we are creating a transluminal anastomosis. Axial ostomy, os is opening, so that we can also go through this os into the extraintestinal space, Axios. And it so happens that Axios is also the name of a famous Greek god called Axios, and it is in Greek mythology the river god. How befitting for the name of a device that enables the flow of contents from an extraintestinal structure like a pseudocyst or the gallbladder into the bowel lumen. So in 2008, I founded Exlumina, that many of you in the audience probably worked with or know of. It started just a few miles away from my hospital here in San Francisco with a mission to develop tools for EUS-guided intervention. We needed these tools and to go beyond into the extraintestinal space with advanced transluminal therapy. X outside the lumen, Exlumina. And this is how I started. I brought on a CEO to basically get the funding for the company. And this is Michael Allen. And these are some of our engineers, brilliant. Here is Tom DeSimio. Many of you have worked with Tom. Tom was my sidekick nurse at California Pacific for many years. And I was able to recruit him to become the trainer and my sidekick working as the CMO at Exlumina. So when you develop a new device, and I learned all of this by osmosis, really, by doing, there are basically 4 med tech stages. So the first stage is proof of concept. This is the design and development of your concept, and it starts with benchtop prototyping and simulation on the benchtop. Then once you have that checked off, you go to the animal studies. So you want to use live tissue. After you have your final design, so the design is, quote, frozen, so it's locked down, you go to what's called V&V. So V&V is verification and validation. So this is actually quite an arduous process because this is the requirement for submission to regulatory, to the FDA, for example. So verification focuses on the product itself. So you go back and you do more benchtop studies to verify. The validation is far more expensive. That's where we're focused on the user, the operator who is using the Axios device. These are our clinical studies. Then you submit to regulatory, the FDA, to get your clearance or your approval, depending on whether it's a 510K or it's a PMA. Now they have something called a 510K de novo. That's what Axios was, which is a grant. The CE mark is the other regulatory agency that you know about. And finally then, when the FDA and the CE gives you the green light, you can move to the commercial launch. And that commercial launch, by the way, obligates the company to follow the outcomes for 6 to 12 months afterwards. So you do a post-market survey and registry to confirm that your device indeed is doing what it's intended to do, but most importantly, that it's safe. So bench-type prototyping is without question the most arduous. Here you can see what we set up for our benchtop work here. So we worked in this room exclusively over many, many months. And here were our goals and our solutions for our lamps. We want lumen apposition, but we don't want that to be so excessive that it results in ischemia. We want to avoid ischemia. The solution was a large flange surface area. We want this lambs to resist migration, but we also want it to be removable. The solution was a double-walled flange construction. It needs to be compressible for axial introduction, but after its deployment, when we pull out back the sheath, it needs to resume its intended original shape, the lamb shape. So it has to resume that shape fully after deployment. So we found out this needs a 48 nitinol wire braid. And finally, we needed coating that is uniform and is durable, and yet it needs to be thin and flexible and conforming. So to find that sweet spot is really no easy task. And we tried many different methods how to coat the lambs. You can use dipping methods. You can do, as you can see here, manual brushing onto the lambs itself. And we found that the manual brushing worked best. And we found that silicone was the best material for the lambs. So just to give you an example, looking for the optimal flange design, it goes through many, many stages until you come up with that flange design that works. So here you can see one of the very first embodiments or designs. And actually these are two halves that are merged together, that are joined together in the middle here. You can see there's no lip here, with the advantage that you don't have anything projecting out. But this really did not have the pull-out force that we wanted. So this got modified to adding this lip component here, but now we are increasing the length, and these ends may project into the lumen and may cause tissue trauma. So then we had to coat this with a special coating to protect it, these bare wire ends, from injury. So just an example of the stages that one goes through until you actually find the optimal design, which is double-walled. The flanges are 90 degrees to the saddle, and the flanges need to be twice the lumen diameter. They have to have a very large surface and a construction that evenly distributes the pressure over that surface area. And it then needs to have that lip, which you see here, to optimize the pull-out force. Now, you go to simulation next with benchtop models, and our engineers constructed such a simulator. You can see two frames. These two frames are mobile against each other to simulate the bowel wall and an extraintestinal wall, which is non-adherent. So these slide against each other, and then we have a membrane here, it's silicone, that simulates tissue. So it would be the gallbladder wall, for example, or the bowel wall. So here you can see in this video quickly how we're able to penetrate through that first wall and enter through the second wall, deliver the distal flange, snug it up against that distal wall. We can see how it pulls that mobile frame up against the first frame, and then we can deploy this and we can pass an endoscope through it. So once we have determined that this works in a benchtop simulator, we can go to the animal studies. Of course, with a rigorously designed protocol. And you can see here the gallbladder of the pig, and we're introducing our labs. You can see the distal flange here. You're all familiar with these types of images now. We can pass our scope through the lambs without displacing it. We can go into the gallbladder. We can visualize the interior of the gallbladder. I was seeing the interior of the gallbladder for the first time in my life, so you can imagine how exciting it was to do this for the first time. And we then followed the lambs after implant over many, many weeks, showing that there was no injury to the wall, no inflammation, no necroses, and that the lumen remained patent. And then on necropsy afterwards, in these survival animals, you can see the two ends. And then this was published in 2011, basically validating the animal results. The verification testing is where you focus on the product specs, and the question is, did you design the product right? So it's all about the product itself. You test the biomechanics, what's the pull-out strength, what's the radial strength, does it do what it's intended to do? And you want to test biocompatibility to make sure that it won't get rejected. All the materials are biocompatible. And just as an example, this is a tensimeter. This tensimeter is used to measure the pull-out strength, so the anti-migration strength, and it showed that the Axios stent had 5-4 greater pull-out strength compared to the wall stent. So that's, you have to always use something that exists in the commercial space to compare it to. The radial strength was less, so that was the compromise at the expense of radial strength. The wall stent had twofold the radial strength, which is one reason why we recommended that you balloon dilate the lumen after placing the stent if you want to get more rapid drainage. Sterilization and shelf life is also part of the verification testing. So you have to show that your packaging meets all of the regulatory requirements. The validation testing then follows. This is about the user interface. Did you design the right product? It's not about was the product done right? Now it's about, is it the right product for the user? So it starts with the indications for use, the instructions for use, and the labeling, the physician training requirements. The physician must understand what the indications and contraindications are and all the warnings on its use step by step. Then you go to the clinical studies. You have to define the requirements. Then you can do the first in man. And finally, you do a registry study, which is multi-center, to document safety and efficacy. And very quickly, the first in man, we were very fortunate to be able to team up with Takao, and at his center in Tokyo, 20 patients, 10 pseudocysts, 5 gallbladders. Of course, a testimony to Takao's skill, 100% technical and clinical success, transluminal interventions in 7 of these patients without complications, stents removed without complications. So this is really the clinical proof of concept now, and then follows the registry. So this is the really expensive part, to do the registry study, multi-center, and we enrolled 33 patients, 7 centers, 6 in the US, 1 in Europe, 22 months follow-up, and technical success rate was 91%. Clinical success also very high, complications here. So all of this was reported then. Raj Shah took the lead in the publication. My name is not on there because of conflict of interest. This led to the FDA clearance in 2014. So this was the breakthrough in terms of becoming available for use in the United States. So we talked about the lambs, but equally important is the transluminal delivery system. Obviously less critical if you have an adherent target organ, but for something like the gallbladder, very critical. And this should be a system that is one step, one single device, and fully exchange-free. In other words, we are eliminating cell injury. We access the target lumen with the device-loaded catheter, and we immediately deploy the device without any guide wire exchange. So an exchange-free delivery system, as elegant as it sounds, is very challenging. We can use bougies, but we know that it may push the wall, the target lumen, away because it's hard to penetrate through the wall. We may displace the target. Balloons, same problem with wall penetration. We can get perforation and bleeding when we dilate. We can use a blade and we can incise, but we risk bleeding. And we can use electrocautery. We often have to resort to electrocautery when the above doesn't work. but we burn a hole in the wall, and that's an unforgiving hole. It's not going to close spontaneously, and there's the collateral thermal injury. So these are all of the challenges that one faces. So I came up with different concepts. At first, I thought it needs to be a multi-layered system whereby we have to create counter traction to make sure we don't push our target lumen away. So I came up with this concept of the dog bone balloon. So you can see the first step is the FNA puncture, and then we can then over that FNA needle, we can advance our balloon. Now this balloon, you'll see when it dilates, it takes on a dog bone configuration. That's the configuration that we're going to use when we deploy our stent, which comes as our third layer. So this is a 3-layer system. So now the third layer is just a tubular stent, but the balloon gives it that dog bone configuration. So this was one way that this could be done, and you can see its resemblance to Axios. Now this is another concept that I had, which is a 2-layered system using a switch blade to gain entry. You can see that this blade flips up as soon as the trocar advances outside of the sheath. Some of you who use Navix may be familiar with this because this was the platform for that. But you can see in this cartoon how this is performed. The echoendoscope now is positioned across from the gallbladder. We see that under EUS guidance, of course. Now you can see they're not adherent. We puncture through with the switchblade, and we create that 3mm opening and immediately inflate a balloon and retract to create counter traction. So this is our retraction to keep that gallbladder wall snug up against the bowel wall, and then we can deploy the distal flange and the proximal flange. And then we can also dilate that tract. So that's another concept. This is a third concept called the cutter dilator. We were very excited about this at one time. You see the needle. You can see we used a different kind of anchor, which is a cage that opens up like this, 4-pronged cage. Here's a cutter dilator blade that can be activated to make a cut, an incision for the desired diameter to deploy your axial stent. So here you can see the cage, the cutter wire here after it's advanced, it's activated. Then we pull back the cage, it engages into the little slots, keeping our wall hugged up in apposition with the bowel wall, and then axials. So these are all the concepts. But where it finally ended after countless months, really it was years of trial and error, is the electrocautery enhanced delivery system, what we call hot Axios. Now we had, of course, tried cystotomes in the animal lab. The problem was the extensive thermal injury, the collateral damage, and that I didn't like. But our engineers came up with this concept of incorporating micro wires just along the edge. These are radially opposed and they converge towards the tip. There's another micro wire at the very tip where the guide wire can come out. So you're all familiar with this. This is a ceramic bougie tip to give it the force, the solidity to optimize your forward advancement, your trackability of your device as you penetrate through. So we're minimizing the cautery effect, and we are maximizing the cutting effect. So really this works really like a blade, like a knife, rather than as a cautery device. When you deploy a lambs that's 1 centimeter in length, obviously there is absolutely no room for error. This must be so precisely delivered. But the good news is we are used to single operator, single hand control when we do FNA. So we're simply applying that where the handle lure locks as we are used to, and then we do a 2-stage release of each flange independent of one another. And that was so critical that these 2 stages are independent of one another, and that you verify that the distal flange is correctly deployed and hugged up against the wall of your target lumen before you deploy the proximal flange. So we built in all sorts of safety measures to ensure that this is delivered accurately and safely, even with adding labels and numbers 1, 2, 3, and 4 to remind the endoscopist of these 4 really simple steps. Because of time constraints, I'm not going to go show you this video because I think everyone in the audience is familiar with the 4 steps of the lamb's delivery. So the lambs is not just about a lumen-opposing metal stent to prevent leakage and perforation. More important, I think, in terms of the future direction, is it's a port for endotherapy. So this has been demonstrated so beautifully by Anthony Teoh and his team in Hong Kong, and they reported back in 2016 on how they could use the Axios as a port to enter into the gallbladder, and you can do really everything you can do in the lumen. And obviously you can do a lithotripsy in there under direct endoscopic guidance, and you could be mechanical, it could be electrohydraulic, but you can do magnifying endoscopy, confocal microscopy, you can do EUS with mini probes. Really, there's no limit because you have extended the reach of the endoscopist into this extraintestinal structure. So the applications right now have been focused on these 2 extraluminal structures. First, our pancreatical biliary. We have pancreatic applications for cyst enterostomy, and we have gallbladder drainage, cholecystoenterostomy. We have bioduct drainage, choledochal enterostomy. You've all heard about these. What we're hearing more about, and I think is the topic of a future webinar, are the enteric applications to create a gastroenterostomy, and in patients who have a bypass stomach, who have had a prior gastric bypass, to create a gastrostomy, what we call the EDGE procedure, to enable ERCP. But what's ironic is that a device that was designed for EUS guided delivery, because we had no such device and we were using tubular stents off the shelf in a off-label application. Now we're using Axios off-label for luminal interventions to treat pyloric stenoses and short strictures such as anastomotic strictures. So I'll end with future directions, and I think I'm right on time now. Really, it's all of you in the audience that will carry the baton, carry the torch forward. This is a platform. It is not intended for the treatment of any specific disease or any specific function. It is a platform that can be applied throughout the gastrointestinal tract. So wherever our endoscope can go, we can apply the LAMS platform. And as you can see in this list, pretty much every organ of the body is accessible through the GI tract. It is literally the window to all the major organs. So I'm going to leave you with 2 quotes that beautifully captures thinking outside of the box. And of course, this legendary thinker is best known for thinking outside the box, who said, "In the middle of difficulty lies opportunity." And we faced so many years of difficulty performing pseudocyst drainage. I certainly did. And that inspired the development of LAMS. If you always do what you always did, you will always get what you always got. So that's why we have to have the courage to plow these new frontiers, to create that fertile soil for innovation. And we need industry to do this, but at the same time, we also want to always put our patients first. Thank you so much again for the opportunity to contribute.
Fantastic, Ken. It is, I must confess, it is extremely rare that we hear such inspiring lectures. We are really privileged to have heard this from you. It was really, really great, inspiring, and very, very informative. Yes, Pradam, anything you have to say?
I just want to say and thank you Very good. Very nice lecture, Bin.
My pleasure. Thank you so much. And I apologize if there was some problem with, hopefully you were able to see the slides okay. It looks great on my screen, but we're all learning this together, how to do our meetings virtual.
We saw the hard work that was put through several years in the development of this wonderful stent.
And that changed the world.
It needed to, it's really fantastic stent and going places, but the hard work behind it is, I got to know first time today, and I'm really very, very impressed. Fantastic work.
It was a decade of my life. I spent a decade working on this. It all started 2008, and patents were filed much earlier because that had been brewing in my mind years earlier. But 2008 is when officially I was able to get the funding through Ex-Lumina to really take a concept that was just a napkin drawing, literally, and then make it an actual device that today I'm using in my hands. So that there's really nothing more gratifying than to know that you can create something from nothing that starts just with an inspiration. And I hope that's the message everyone in the audience is getting. The inspiration is so important. We're the ones in the trenches. We know what our patients need. The engineers must follow our instruction, our marching orders. We know what our patients need, but we need their partnership, obviously, because we're not engineers, and we're certainly not entrepreneurs. I leave that to others as well. We're in the business of medicine and healthcare.
So, Ken, those 8 years, was this done in your extra time, or did you sacrifice your clinical practice also?
So I did take one day of the week. Monday was my Ex-Lumina day, and I was in Mountain View with the engineers in the lab. On the weekends, we actually did the animal lab studies because that was, so talking to Simeo, by the way, he was always cursing because I worked him very hard during the week. We worked, did ERCPs till midnight. And then on the weekends, we were in the animal lab, and I can't tell you how many animals I really lived in that animal lab, but it was so important to get that experience and understand the hurdles before then going to patients. So yes, I sacrificed some of my time, but the one thing I did not do, by the way, because I was invited to do that, which is the only way if your intention is to retire on your cruise ship. Manolo is going on a cruise. I hope he's the only one, but otherwise, please wear a mask. If you want to have your own cruise ship, well, then you become a full-time entrepreneur. But if you want to stay a doctor, as I did, then you'll get diluted out completely. That's just the way the game works. But it's okay because at least somebody else is paying for it. In the beginning, you're paying for everything. And that only can go so long, right? When you file the patents yourself and so forth, it's coming out of your pocket. You can't continue that. So this is the way you got to think of it. If you find a way for someone else to pay for it, that's amazing. And the goal of the doctor is, I want to get to the finish line. I want a product that I can use in my hands in my lifetime. So yes, I stayed an interventional endoscopist 4 days a week.
Fantastic, too good. Thanks, Ken. I don't think there can be any questions on this lecture. It's a marvelous lecture. Now hear from Amrita how we use Axios stent, the practical tip. Amrita?
Thanks, Vinay. Yes, I'm here. Can you hear me and see me? See my slides?
Yes.
Wonderful.
Yes,
well,
can.
First of all, thank you again for the invitation, and really congratulations to the organizers for this great concept. I mean, it's such a treat to get to hear a little bit of the thinking of all of these innovators that spoke today and a peek into their minds. And it's definitely inspirational, particularly in this time when we've had a lot of time to think about what we need and maybe what we can develop in the future. So Vinay asked me to keep it pretty basic, and so that's what I'm going to do today. Ken, I thank you for inventing this device. It's certainly become one of my favorites, and I love to talk about how to use it and practical tips. So this is a nice treat for me as well. And it's really just I'm going to focus on basically the steps of deployment, because I think that's really what most people kind of have questions about. And once you get that down, then you can think creatively of how to use it for all the indications. And, you know, I'll just go over a few things, but really this was discussed in sort of how we saw this stent develop. Clearly, we're taking advantage of the fact that it's a fully covered stent, so it's going to help us prevent some of the complications of going across lumens. The opposing aspect of it will allow us to prevent migration and really pull together lumens with potential spaces between them, which had never been done before. It's, as you know, both in a cautery enhanced and a cold version. And I think the cold version is not what I'm going to talk about and is used in some more of the off-label luminal indications. So we'll focus on the cautery enhancement and what that allows us to do. Commercially, it's available in multiple sizes. In the US, 10, 15, and 20 millimeters, but in Europe, and I don't know about Asia, it is available in smaller sizes as well for a lot of the pancreaticobiliary EUS work. And access. And I think what's really important is that it can be performed wire guided, but now more so freehand. And this freehand aspect of it is really just made possible by the cautery enhancement, and I think has made a world of difference, and really is sort of my go-to method, and I think of most of the experts that you hear on today's panel and elsewhere. It can also, because it's really the first of its kind where it's specifically made for EUS, as Ken mentioned, we know what we need for our patients and what our procedures. And so for the first time, all the components of it are visualized by EUS. So the placement can be by EUS alone and doesn't necessarily require fluoroscopy or switching to an endoscopic view, although there are certainly mechanisms in place and markers to do so if that's the way you choose to or need to for certain types of procedures. Again, because of this large diameter that we're instantly creating, we can go on to do further work that you saw in some of the, similar to the stents that you've seen in some of the other talks. So just to focus a little bit on that tip, because I think it's really important to understand what's happening when you think about the different steps. As he mentioned, this ring here at the very edge is the actual cautery portion, along with the two wires that run along the side of the of that conical tip there. And that's important to think about because this is where your axis is going to be created. And the tip itself is about a 3 French tip, and then it dilates up to a 10 plus French catheter. So again, here is your needle in terms of consolidating your Seldinger techniques. It's your needle access, it's your fistula creation, your dilation, and then ultimately your stent introducer, insertion, and deployment all in one. So again, the important thing to think about here is with this tip, you really want to have en face contact between the ring and the tissue in order to maximize the cautery that's going to really create your access. Similarly, you think about that these wires are continuing to burn through. So it's important that that contact continues smoothly as you go through the lumen, the muscle wall itself, as opposed to sort of just a quick spurt on the cautery, because you won't actually create your access. It's also important to think about when you think about going through multiple lumens, not just a fluid collection. So from the duodenum into the gallbladder, or from the stomach into the jejunum or the duodenum, that this cautery tip needs to make contact with each muscle layer, not just the first one, and then it creates dilation. So you have to think about that a little bit as you're inserting and simultaneously applying cautery during the placement. And if we look here, this is the covering of the stent, which is in an elongated state, and just like any of our other covered stents that we deploy. And it's important to know that the black mark is where sort of the flange is. And so if you are going to look endoscopically to deploy, for example, the second flange, this black mark is the indicator of where that flange is and where, if you're appropriately positioned. And so just to mention again, it is feasible to do this without fluoroscopy because each of these components are can be visualized by EUS. So, so Ken mentioned that it's 4 steps, and that is traditionally how it's taught. It's certainly how it's marked on the catheter, but I would actually argue that there are 5 steps, and that has to do with sort of evolution of how we have recommended, or how it's been recommended, that for optimal deployment of the stent under EUS guidance, and particularly deployment of the second flange. So the first step is going to be your actual access and the entry of the catheter system into the collection. And that's going to be a combination of getting this catheter out of the scope, putting it up to the first lumen wall, burning your way through or getting through the actual lumen, and then advancing far enough into the collection or space that you will be sure to be deploying the stent within the collection itself. That's all contained in that first step. And what's important to think about also is that a lot of the times when I'm teaching this, is the part that's important to understand is what's happening up here at the handle. When you have an understanding of that, it can make deployment much easier. So I break the handle up into 2 parts, the bottom half and the top half. The bottom half I call the catheter portion of the handle, and the top half I call the stent portion. In terms of the steps, the first step will involve this catheter portion, or the bottom half of the handle. The second step is the deployment of the first flange, and that will be done again with the top half of the handle. And then the third step is going to be creating that apposition and pulling the catheter back into place so that you can make sure that the second flange will be deployed on the luminal side of your, within the lumen. And so again, this has to do with movement of the stent, so it has to do with movement of the catheter, so it will have to do with the bottom half of the handle. The fourth step is the deployment of the second flange, and again, that has changed in terms of the way that we have recommended doing so. Currently, the optimal way to do it is EUS guided, which means within the channel of the scope itself. And I'm going to show videos of all of these steps, so bear with me. But again, this will have to do with the top half of the handle because it has to do with the stent, it's the deployment of the stent itself. And then this last step that I'm sort of adding in is actually getting the deployed stent out of the scope and making sure that you've done so you're not at risk of pulling out the entire stent and defeating the purpose of placement. And so this fifth step, again, is involving moving the catheter and even using the catheter as a pusher. And so we'll kind of focus on the bottom half of the handle. So I'll just focus on a few tips for each of these steps. The first step, again, being the entry of the catheter across the lumen wall. This is going to be done under EUS guidance. When you think about, and again, I'll show this in the video, but that angle, you really want it to be perpendicular to your wall through which you're accessing. And this is true for any type of EUS guided procedure and any type of, particularly for Axios placement, whether it's for a walled off collection or gallbladder or even a GJ. As has been mentioned before, with all these methods, you want to check the Doppler to detect vessels in the wall to prevent intraprocedural bleeding. And then is when you're going to begin these steps. So the first step is to unlock the catheter just to allow you to be able to move it into place. You see the catheter come out and you tense the tip of the catheter to mucosa. What does that do? That really allows you to ensure that the ring of cautery is maximally up against the mucosa at a good angle and will allow for you to have quick cautery access into the area of choice. Then you make sure your cautery is attached. I apologize for the sirens. And you check your settings, which on a Irby unit, for example, is auto cut 100, effect 5. You then, this is really the important part, is to advance the catheter slowly and steadily while applying that cautery. You don't want to do a jab the way that we do sometimes with sampling in FNA, where it's a quick puncture with the needle. You really want that to go in slowly in order, again, for that ring of cautery to have enough time to apply and create access. Once you're inside, you take your foot off the cautery, but the step 1 is not over. You still want to advance the catheter far enough in order to make sure that your stent will be properly deployed, the flange will be properly deployed within the collection. And so this here is kind of a video I created just to keep in mind. The EUS video procedure is not the same as the room view video, but this is kind of the best I could deal with, and working with my sort of amateur video skills. But just to focus on what's happening here simultaneously here, and it just also emphasizes that these are the exact same steps regardless of what type of Axios placement you're going to do, whether it's rectal in this case, or transrectal in this case, or walled-off necrosis, pancreatic necrosis in this case. So this is step 1. The first thing that's happening is you're unlocking the catheter. You're now focusing on the bottom half of the handle and bringing the catheter out. Here you see it. We then attach the cautery to be ready to puncture through, and then create a good angle, so perpendicular, and then it's a quick hit of the cautery, and again, continuing to advance that catheter all the way in. And one thing that I can just sort of re-show here is that you want to make sure that the catheter goes all the way in enough so that it's at least a thumb's width with the distance between here and here is no more than a thumb's width apart, and that really tells you that you have enough catheter in. So for step 2, you have deployment of the first phalange. Again, this is all under EUS guidance. It's important to make sure here that your catheter portion of the handle is locked, because you don't want inadvertent movement of the stent into the collection. You're going to remove the yellow safety tab. You're focusing on the top half of the handle. You unlock the stent lock, and then you're bringing the knob up to the position number 2 until it clicks, at which point the stent will lock automatically. So again, to take that into the video, this is taking the safety handle off, then unlocking the stent. And here you see the stent starting to deploy as you're bringing the gray up to the number 2, and then it clicks in place, and then this locks automatically. Just to show that one more time, safety off, unlocking the handle, bringing it up, and then you see this, the flange start to deploy. Again, step 3 has to do with the catheter again and creating the apposition, which means moving the, bringing the catheter up and the deployed flange up to the internal wall of your collection or your gallbladder or your small bowel lumen. So you're going to unlock that catheter lock in order to allow you to make that movement, pull the catheter handle. And here's where you want to visualize the stent beginning to deform, because what that means is that it's now hitting the inside of that wall, and it's in the proper place for you to start to think about deploying the second flange, and it's going to create that apposition. We kind of refer to things like football, or sometimes an egg shape, and that again just is really implying that something is pressing down against that flange to cause it to deform. It is worth noting that when the 20mm stent came out, there was a slight difference in the way that we sort of talked about it being at an optimal position. In this, when you deploy this stent, you actually see the introducer kind of move eccentrically towards the superior edge of the flange. And that is actually more of an indicator that you're in the right place to deploy the second flange. And then of course, once you're finished doing this maneuver, you want to make sure that you lock the catheter lock prior to deploying that second flange. So this is step 3. We're unlocking the catheter here, we're pulling back, and you see as it pulls back, it sort of creates this deformity in the flange here. This is a 20mm, so it's not as much of a deformity, and really the focus also is on this. This is the introducer, and it kind of eccentrically is moving towards this superior edge of the flange. And then, of course, the fourth step is the deployment of the second flange. Again, we currently recommend this to be done under EUS guidance. And actually what that means is that you don't see anything happen, because you are really just deploying the flange within the channel of the scope itself. And you'll see in the video that it's neither EUS guidance nor endoscopic guidance, nothing happens, but you don't really need to visualize the catheter itself. You want to unlock the stent lock, and then important also not to really move your scope during this this maneuver in order not to pull the stent out of the entire collection. So for step 4, again, here you see nothing happen. You unlock this and you start to pull up, and you can do this very quickly. And just one more time, nothing's actually happening here. So if you don't see anything move, don't worry, because the stent is just being deployed within the channel of the scope itself. You see it get pushed out just a little bit here, and that might be from a slight movement of the stent forward as the final flange comes out. And then this last what I call the 5th step or added step is really just pushing the deployed stent out of the scope. And for this, you can switch, and you should switch to your endoscopic view. So again, important not to move the scope too much before making sure that the stent is fully out, because you could pull, if you pull back too much with your scope, you could pull that stent out of the collection. You switch to your endo view, you unlock the catheter, and now you're going to use the catheter kind of as a pusher with some abrupt movements back and forth. You big wheel away very gently to be able to see the lumen wall, and you start to see the stent itself. You might torque the scope a little bit to the right and back and forth. And again, this is just kind of gently allowing the deployed stent to come out of the channel of the scope itself. And then you'll be able to visualize that stent. If you are going to do further work, or you're worried about the placement and you think there might be misdeployment or impending misdeployment, you want to make sure you get your wire in. So before taking the introducer delivery system out, you can insert the wire through the wire port directly into the space that you just created access. So step 5, you're just unlocking the catheter, and then here we're just going to push down on it a little bit, and as we do that, we look away with the big wheel, and you see the stent be fully deployed. And then all together, this is just the video in summary. Catheter coming out, apply cautery, insert all the way, deploy the first stent, pull back, create apposition, deploy the second flange in the channel of the scope, you see nothing, and then you push that deployed stent out. This is then followed by placement of a wire, and in this particular case, early on, we were dilating and then placing a double pigtail stent. I don't dilate anymore, but certainly do place double pigtail stents now. And with regards to the question of double pigtail stents and when I use them, So I use them certainly for anything that has some degree of necrosis or thick material in order to make sure that we're preventing occlusion of the lumen. Even though these are wide lumen stents, some of this material can certainly get in the way, as can food and contents within the stomach. If it's an infected pseudocyst and you want to make sure that you're maximizing drainage to help clinically with the patient, or you might be placing a nasocystic tube along with the double lumen stents. For EUS gallbladder drainage, in order to ensure that there's no migration of the stent, because that's still possible since you have two free floating lumens. And then if there's concern for a disconnected duct syndrome from the beginning, then I typically place the double pigtail stent, even if it's just a fluid-filled collection, because it will allow for there to be some amount of space so that when I return to remove the Axios, I can still leave in a double pigtail stent indefinitely in order to help manage the disconnected duct syndrome. And then fluoroscopy, as I mentioned, this can really be done by EUS alone, but when should you consider using fluoroscopy? So I actually think it's important to use it if you have really thick necrosis as determined on pre-procedural imaging. And one of the reasons is that sometimes that necrotic material can be so thick that it actually impedes the deployment of that first stent. And that can sometimes be a little difficult to detect fully on EUS. And it's important to know whether or not the flange has really started to open, because if you pull back to create the apposition and it hasn't opened enough, then you will just pull the stent out. So fluoro kind of helps in that situation. In addition, if you're planning to do immediate necrosectomy afterwards, it's certainly helpful during those maneuvers to have fluoroscopy. If you're going to leave a nasocystic tube, you do want to have that as well in order to make sure as you're pulling the scope out that the tube is still staying in place. And then I think that you should use fluoroscopy for any fluid collection indications, such as the gallbladder drainage, DJs, even afferent limb syndromes, which can oftentimes be very simple and mimic pseudocyst collections. But you do want to make sure that you're on the right side of the obstruction, which oftentimes could benefit from using contrast and fluoroscopy. And then procedures like EDGE, again, where you want to use contrast to really understand where you are location-wise. For sedation, Vinay, you touched on this earlier, so I won't focus too much, but if you have a large collection that you anticipate at least 1 liter of fluid coming out, you probably want to intubate in order to prevent aspiration. If you're going to do some longer work like necrosectomy or irrigate with saline or hydrogen peroxide, I certainly recommend general anesthesia. And then if you are going to do procedures such as GJs or edges, in which cases there are certain increased risk of adverse events that might require salvage maneuvers, such as NOTES type procedures, and then again, I certainly recommend general anesthesia and definitely using CO2. Anthony is going to talk about this, so I won't focus, but the main complications that you see here, I just mentioned very briefly, quick ways to prevent them. For bleeding, certainly you want to do pre-procedure imaging, which hopefully you're doing anyways, using color Doppler during the placement. For pneumoperitoneum, if it does occur, some needle decompression could help, and then the fully covered aspect of the stent should help seal the leak. Stent migration during the procedure itself, quickly establish wire access if you're concerned, and then place a larger fully covered metal stent through the lumen of the Axios. For delayed migration, double pigtail stents have been shown to help. For tract occlusion and infection as well. And for pseudoaneurysm bleeds, for example, again, pre-procedural imaging and IR embolization prior to drainage is how I proceed. In terms of removal, in terms of my protocols based on Shyam Varadarajulu's work, I think this has become routine to perform some type of imaging about 3 weeks post-placement, and if the collection is nearly resolved, then to repeat the procedure 1 to 2 weeks later with stent removal. And again, think about leaving a double pigtail stent if, for example, if there is a decent enough pocket or if there's a disconnected duct syndrome. If further necrosectomy is needed, then repeat with removal and placement of multiple double pigtail stents. And or you can replace the Axios, although it's certainly not an indicated use of the stent. And it can be removed simply with rat tube forceps or a snare. So in summary, I think it's really important to understand the components of the stent and the delivery system in order to make this as easy and efficient as possible, and also to deal with the potential complications as they occur and salvage your procedure. Think of it as think of the handle as a catheter aspect and a stent aspect, and understand the 5 steps of deployment should get you through any procedure. Early recognition of that misdeployment is really important, and then kind of pausing and stopping to manage prior to continuing should allow you to still have success. And some of these ancillary issues, I think, just depend on the indication. Thank you.
Thanks, Amrita. Wonderful lecture. You created.
Thank you.
Very nice coordination of the two side by side. Very, very nice videos. And the 5th step I liked. I think it's a good idea to think of it as 5 rather than 4 steps. So there is a question from the audience. Is it necessary to see the black mark endoscopically during step 3?
No, it's not. So I think that if you see that deformity start to occur in the deployed flange within the collection, that's an indication that the flange is all the way up against the wall, and that you can actually proceed with deployment of the second flange. Again, remembering that the flange is going to get deployed in the channel of the scope. It's really important that you make sure that the indication for doing the procedure is right, in the sense that you don't want the distance between the wall of the lumen and the wall of the collection to be greater than 1 centimeter. And I think you alluded to that when you were talking. If that distance is too great, then there's a problem, because that means that you might be all the way up against the wall, but you haven't reached the inside of the lumen. If you choose to do it endoscopically, then yes, you must see the black mark prior to deploying the second flange.
Okay. And there's another question. What is the...
Oh, one more thing, Vinay. I would say that and I think Manolo and others might be able to comment as well, that for GJs and gallbladders, not as much gallbladder, but for GJ, I would say that confirming the black mark is a little bit more important than in any of these other procedures. So there I do keep like a picture-in-picture, and I do have a little bit of view of that black mark.
Okay. Another one question unrelated to Axios. Hydrogen peroxide, what is the strength that you use?
I use a 1-to-1 dilution. So I think it's a 6% hydrogen peroxide solution that we have here, and then I fill like a 300. My syringe is a 60 cc syringe, and I do 50% saline and 50% hydrogen peroxide. I don't use it that much, and if I do use it, and in terms of how much I place, probably about 120 cc's. I kind of flush it through, I let it sit for a minute, and then I suction it all out. Again, I don't want there to be hydrogen peroxide sitting around in the stomach, and during extubation, the patient aspirates, because that can be quite dangerous.
Okay, thanks, Amrita. That was wonderful, fantastic lecture. Let's move on.
Thank you again for having me.
Thank you. Thank you. Last lecture of the day, Anthony is with us, a very, very important lecture about the prevention of adverse events of EUS guided drainage.
Thank you. So good evening, everyone. So it's getting late in Hong Kong, but I'll try my best and talk about adverse events. So I think to many of us practicing interventional EUS, having adverse events is like a nightmare because very often management will be difficult, and then you're struggling with a lot of things. I think to different people, nightmares mean different things. So to me at home, sometimes my kids, they are nightmares. To some of us, Trump can be a nightmare, but to all of us, COVID is our biggest nightmare. So when I first started doing EUS, one of my teachers told me in interventional EUS, when you succeed, everyone praises you and you become a hero because you are able to do something that most people can't do. But if something happens, if you misdeploy a stent or you do some adverse events happens, you fail miserably. So why is that? So when something happens, a complication, adverse events happen during the procedure. So for example, misdeployment of stent, then you have two problems to deal with now. One is the initial indication, and two is how to salvage the issue that you have created. So if you are just starting to do these procedures, you really need to ask yourself several questions. First, will you be able to deal with the complication yourself? Should you continue the procedure, or should you go to plan B? There is often a percutaneous or surgical options for these patients. And if you do choose to continue the procedure, can the patient tolerate another procedure or even another failure? Do you have someone who has more experience around you that can do a better job than you and help you with the procedure? Do we need to ask other colleagues, friends in those other disciplines to help you? So it's a lot of questions that you need to think about, especially during a very stressful time when something happens. But you should think about it before you embark on salvaging the procedure. So potential issues, stent misdeployment, stent migration, blockade, perforation, foot impaction, bleeding. I think for me, the first few, most of the time nowadays can still be dealt with endoscopically. Bleeding, most of the time we can deal with endoscopically, but sometimes we would need a multidisciplinary involvement. Okay, so I'm gonna go through these complications, adverse events. Many are my own experiences, but I'm glad I'm not increasing the number of videos in my collections. This is one of our earlier cases in gallbladder drainage. So case 2, stent was inserted into the gallbladder from the stomach. Distal flange deployed, proximal mark for proximal flange not seen. I was struggling to see the flange, eventually deployed the proximal flange. Because I didn't see the proximal mark, so the stent was not long enough and it migrated into gallbladder. So because the wire was in situ, so I was able to put in a additional straight stent through the wire. So if you are new to these procedures, having a wire is very important because it can help save you and also can salvage, help you salvage the procedure. So at this time, we were still using the code Axios, so we needed to insert the guide wire, diet the track, followed by insertion of the stent. So right here, you can see I was struggling. I deployed the distal flange. My scope position, I was trying to pull back to see the proximal flange. At that time, we were still not practicing the intrascope deployment. And then you can see I was struggling. I was trying to pull my scope, torque my scope sidewards, pulling, and eventually I think I deployed the stent. But the entire stent was in the gallbladder, so I had to insert an additional straight metal stent on wire so as to finally bridge the misdeployed Axios. So this is the final image. You can see Axios in the gallbladder and a straight stent between the gallbladder and the stomach. This is a CT scan, the gallbladder, the stent in the gallbladder, and then straight metal stent bridging the gallbladder to the stomach. So when you first start doing these procedures, especially if you're not very familiar with it, the wire is very important. You should have a good guard of the wire, making sure it doesn't come out of the target organ prematurely, because if anything happens, you can still use it to salvage the procedure. This patient, again, another gallbladder drainage. We now advocate deploying from the duodenum. This was the plan for this patient initially, but she was actually on long-term cholecystoscopy, so I had to struggle a bit to see I have a good view of the gallbladder. But at the end, I deployed the stent and found out that I was actually at the antrum. So the problem of this stent is that it's almost obscuring the pylorus. Food would preferentially go through the stent into the gallbladder. So several issues. So again, there's a risk of recurring cholecystitis as well. So in an attempt to prevent food from going into the Axios, I placed two plastic stents, kept the patient faster for longer because she was on percutaneous cholecystostomy. I had daily aspiration, but there were small amounts of food residue aspirated out every day. So this is what it looks like on X-ray. You can see the Axios plus 2 double pigtail plastic stent and the percutaneous drain. So what to do next? I know the patient is having small amounts of food going inside the gallbladder. The stent was quite recently inserted, so I cannot really remove it because the tract is not well formed. She is very old and probably not a candidate for cholecystectomy. So at that time, I was planning to sit tight, keep the percutaneous drain, have a regular aspiration, and hopefully can wait long enough to remove the stent early and close the tract. The patient suffered from several episodes of sepsis, so I had to repeat OGD twice because there were a lot of food getting to the gallbladder. Her percutaneous drain unfortunately slipped out during one of these procedures, and in an attempt to try to block food from getting inside the gallbladder, I was actually able to insert up to 9 plastic stents into the gallbladder. So this is what it looks like. And still, there is still some space between the stents into the gallbladder. So food was still getting into the gallbladder, and she was still having some on and off sepsis. So finally, 2 weeks has passed. It was the longest 2 weeks for this patient. This is what it looks like. So the stent was here. There's a lot of food. I used the rough net. I thought it was gonna take a long time, but eventually all the food was removed. So I decided to remove the Axios as well. So all this food. The gallbladder has clear stones. So I removed the stent. You can see almost like a double pylorus appearance. So luckily at that time we still have the overstitch. So I used the overstitch to close the opening. And this is what it looks like after stitching. So luckily I was able to overcome this issue. So this is a CT scan afterwards, and no contrast was going into gallbladder. But during management of this patient, this is also a very interesting phenomenon. So I witnessed the migration of gallbladder stent. So this is what it looks like on day 0. Day 11, you can see the stent already migrating out of the stomach. And day 17, almost completely gone. So what is happening is that I just want to show you the anatomy. So this is the patient with acute cholecystitis during surgery. So after clearing all this omentum, this is gallbladder. This is the duodenum, and this is the antrum. So if you drain from the antrum, it's actually a fair distance from the gallbladder. But if you drain from the duodenum, it's right next to the gallbladder. So when you drain from the antrum, you're actually pushing the stomach towards the gallbladder. Place the stent in here, and although it looks very looks like the stent, the gallbladder and the stomach is very close. Actually, there's some tension, and when you remove the scope, the stomach tends to go back to its original place, and essentially the stent is being pulled out like a berry bumper condition. So that's what's happening. Stent migration during HCS. I think we had some discussion about this during various lectures. I think in terms of biliary drainage, HCS is probably the most complicated one. There are several reasons for this. The IC is smaller to puncture. Guide wire manipulation is sometimes difficult. Stent placement, we need to have a nice landing site in the liver. We need to have a longer stent in the stomach. And there is also a risk of stent related complications like migration. So during HCS, you need to be aware there are 2 dents. One is the where the stent comes out from the liver, and the other dent is where the stent is entering the stomach. So Manolo say we try to decrease this distance as much as possible. I totally agree. But you have to be aware that these are the points where the stent is entering or exiting various organs. So in the past, if stent migration happens, then we have no option but to do surgery. This is one of the earlier cases where a stent has migrated out of the stomach. You can see a big hole in the stomach, and this is in the hole in the liver. I think some of you may have seen this case. We try to salvage this misdeployed HCS endoscopically. I know Manolo has a video of doing a similar procedure with notes. I think if we can do it endoscopically, of course I would prefer that. So in this patient, initially part was okay. It seems that the stent deployment was inside the GI tract. But I think my trainee tried to push the stent back into the stomach. This is still deploying. Right here, the scope is being pushed, and actually the entire system pushed into the peritoneal cavity. So this is something that shouldn't have been done. So right here, the entire stent is in the cavity, in the peritoneal cavity. A wire is still in situ. So the initial plan was to use this wire to insert an additional stent. So what to do? Again, when this happens, we need to think about options. Of course, the initial aim is try to do a stent on stent. But of course, if you don't have the confidence of doing so, you should think about other options. So unfortunately, during the insertion of an additional stent, the wire came out as well. So now I have no access. There's a big hole right there. I wasn't so brave as Manolo to do a notes retrieval, so I decided to close this opening first with the OTSC clip. And after closure, I changed back to a EUS scope. And right there, I had a very nice position with the stent. So I thought this might be a good angle for puncturing and also inserting a guide wire into the lumen of the stent and perform a stent-on-stent placement. So needle coming out right there. Change the angle of the scope. Wire going inside. Now I have a very stable scope position. It's long scope position, but it's stable. The wire going through the misdeployed Axios and back into the bowel duct. And then afterwards, it's the usual business. Cystotome followed by balloon and then stent on stent. So this is one way you can try to salvage a misdeployed Axios into the peritoneal cavity. And we were happy afterwards. But of course, it may not always be possible. I was very lucky that this Axios was in a nice position. If the stent was pointing downwards, then it would be much more difficult to salvage using EUS. So procedurally, this patient was fine and discharged back to Convalescent Hospital. Perforation, this is again an interesting case, acute cholecystitis, gallbladder drainage done. First half done by my trainee, everything was fine. And then I decided to take the scope off him because I wanted to have better drainage of the gallbladder. So the stent was facing towards the duodenal wall, so I had to do a torque maneuver to try to look to see the opening of the stent. So pay attention while I was trying to do this. I turn, and then I try to turn it, and then suddenly I see this. So I'm gonna show you again. Okay. All right. I turn, and I suddenly see the extraperitoneal fat. So I was a bit puzzled what happened. And then I go back inside. There was a lot of blood. Seems like the stent is still there. So, and then I was trying to assess the damage that I've done. There's a hole right there. There's a hole right there. It's actually right next to the stent. So what I've done is actually I have entered the space between a newly created anastomosis between the stent and the duodenum. And on contrast injection, you can see leakage. So no choice, have to try to close this endoscopically. I wasn't sure if this was possible. I added a few clips around that hole. So more clips over this remaining opening. And then eventually I was happy because I was able to close the hole. There was no more contrast leakage. And it was quite a stupid mistake on my side. Bleeding. So this is one of the older cases, a patient with a pseudocyst or water necrosis. So this was actually drained by plastic stents. And after 2 weeks later, the patient came with sepsis, HP drop. You can see some fluid outside in this liver subphrenic area. Plastic stent is still inside you. There's a lot of blood clot and substance in the stomach. Stents are still present. But you can see the two lumens right here. There's fluid collection and the stomach is actually separating. So this happened obviously after drainage. Why is it separating? My postulation was the collection was actually drained too high in elastic curvature. So when the collection collapses, it actually goes away from the stomach. And when the tract separates, it creates a site of bleeding. So when there's bleeding, what to do next? Again, several options. Because the patient wasn't actively having hematemesis, I decided to go in with endoscopy and take a look. And initially, this is a plastic stent. Actually, I didn't see any bleeding. The tract was a bit small. I had to dilate with a balloon. So after dilation, I went inside the collection. There were a lot of solid material. But as I was coming out doing necrosectomy, I saw a glimpse of blood. So I figured out I should go inside, and there is just blood everywhere. So at this juncture, you try to stay calm. I insert the scope deeper. I didn't edit this video at all because I just want to let you see how frustrating feel the pressure. Just now you had a glimpse of a fountain of blood. So very poor visibility. So I could see a vessel right there. So I thought this is my only chance. I overshoot my scope into the collection. I open the clip. I pull back. I wait for the opportunity. So right here is a vessel. Luckily, I have a stent, which is kind of helping me. Right there. So I decided to give it a try. So now or never, right? So the clip is deformed, a little bit worried. But I have a good position. So we decide to close the clip. Slowly, 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 please. And then we were able to catch it. So, yeah, I mean, I think most people would have gone for angio. Haven't seen such a bleeder, but this is possible as well. Okay, how are we going for time? Okay, so perhaps just one more case. This is actually a case from Itoi sensei. HGS, patient with a recurrent CA rectum metastasis, had PTBD performed, requested for internal drainage. This is a difficult case. So there are several options. Of course, you can do internalization from PTBD or HGS. I think he decided to do a PTB HGS. So this is a difficult case because the duct is completely non-dilated. But have no need to know he has exceptional skills. So first, contrast injection, and on EUS view, the ducts are completely non-dilated. So the only way to see it was to find the location of the catheter and use this as a mark right there. So, but there's also a vessel right in front of the bile duct. So what should we do next? Stop the procedure, continue procedure? Of course, knowing Itoi, we continued. So the needle going through here. Right there. The vein is right there. The duct is here. So puncture or not puncture. Eventually, he went through. But it seems to be going through and through the vein. Okay, so at this point, I'm not sure how many of you would proceed because knowing that you have punctured through the vein, it's a chance of causing much bleeding. But having said that, after going through the vein, the wire was also going into the bile duct. So I think Itoi decided to proceed with cystotome dilated tract, but now we have a problem. A lot of bleeding right here. You can see blood collecting in between the liver and the stomach. It seems to work quite fast. So no choice. So the only option is try to complete the procedure as quickly as possible. And hopefully with this metal stent, it can help compress on the bleeding site. And afterwards, seems like the bleeding has stopped. So definitely not for the faint at heart. I think most of us would have stopped knowing that we have punctured through the vein. So, but then if there is bleeding, I think this is a good case showing that the metal stent can actually help compress on the bleeding site. So afterwards, I think the patient had an infection of the collection, but that was dealt with easily. So I probably won't finish talk about this case because of time constraints. And I'll just finish with this slide. So tips and tricks, have a very good planning because most of the ES procedures, once you start, you have no choice but to complete it. So you need to have good planning, think of options, think of potential issues, always have a plan B if it doesn't, planning doesn't work. Go slow. If you're attempting something new, have someone experience around you because there is no room for error. Very often these are one-shot procedures. Have good nursing staff. If you're performing some difficult procedures, accessorize yourself. This is very important. It's very frustrating if you run into problems and you don't have the proper gear to deal with it, and try to look for backup. So complications in interventional ES can be terrifying. Make slow, cautious steps in learning EUS. Be friends with radiologists and surgeons. It's very important. Initial learning best in the presence of experience in the sonographers. But definitely it'll be great rewards in successful cases. And it's a very exciting time for interventional ES. So thank you for your attention.
Thanks, Anthony. It's past midnight in Hong Kong.
Yeah, 12:30.
You are showing us horror movies. Fantastic collection of cases. Fantastic collection. My God, it's really not for the faint at heart.
Yes, and hopefully everyone learn something and not go through the same mistakes that I made.
No, but brilliant cases. Fantastic collection of cases. I think a fitting finale to the webinar.
Thank you.
Yeah. I don't want to ask any questions now.
Okay.
Laura, can we have a good group photo of everybody who is present? Hi, Ali. Where were you? I didn't see you in the whole webinar. Is Amrita there? Lawrence, no, Lawrence is too late. Ken, Dixon. Okay, I think this is all.
Okay.
Let's take a good picture.
Okay.
Smile.
Okay.
All right.
Taken?
Thank you very much. Thank
Yes.
you, Vinay.
Thanks
Nice
a
to see you,
lot.
Thank you,
Zara.
everyone.
Thank you, Olympus. Thanks, Jason. Thanks, Arun. Thanks, Flora, Manolo, Lazaro, Ellie, and Anthony, of course. Thanks a lot. It was a wonderful, wonderful learning session. We learned so much today. And a
Thank you,
great
Vinay.
practical as well as
Excellent.
institutional. Very, very nice. I'm very, very happy. Thanks. And let's wait for the next webinar. Let's do it better than this one.
Okay.
Thank you.
Good night.
Okay. Bye-bye.
See you soon.
Thank you. Thank you, sir.